أيوة دكتور تفضل.
بسم الله الرحمن الرحيم. والصلاة والسلام على أشرف المرسلين. We would like to open this course on fundamental of pediatric neurology, and it's my pleasure and honor and thanking the Pediatric Neurology Society for inviting us to participate in this event. This course is going to highlight all about fundamentals of pediatric neurology, which are really important for the neurologists as well as general pediatrics, as well as family medicine and other practitioners who are dealing with the pediatrics with general pediatric neurology problems. I would like to really thank the organizing committee as well as scientific committee for organizing this event, as well as would like to thank the event troupe for sponsoring this event, and also all our speakers who are going to participate in this course. Without any further ado, we would like to start with our first speaker for this course, Dr. Muhammad Salumi, who is a graduate from Qasim University and joined the pediatric residency program, and I have the privilege of being a colleague with Dr. Muhammad from 2011 until 2016, when he finished his residency and he had a board certifications in pediatric neurology. Subsequently, he went for epilepsy and EEG fellowship at King Faisal Hospital, and when he finished this fellowship, he went back to be an assistant professor at Al Qasim University, and now he's practicing in Al Qasim as a pediatric neurologist. Dr. Muhammad is going to talk this morning about the first episode of febrile convulsion, which is a very important topic for everyone who is dealing with kids in the early age of their life. Dr. Muhammad.
Thank you, Dr. Ahmed, and thank you for the organizing committee for inviting me and giving me this opportunity to present this topic. Okay, how to approach first afebrile conversion, or how to approach the first seizure? It's very important and very common question, either between the neurologists and also between the common physicians or the general physician. Okay, first of all, we have to differentiate between what seizure and epilepsy, because this is very important question to be answered. Seizure, it's the sign or symptom or transient occurrence of the signs and symptoms resulted from abnormal, excessive, or synchronous neuronal activity in the brain. While epilepsy is the neurological condition characterized by recurrent and unprovoked seizures. If we take this clinical scenario and start from that, 3 years old, previously healthy, presented to the ER with convulsion today morning. The first important, the most important step to evaluate this child is history. Always we say that the approaching the children with abnormal movement or convulsions is started and very important by the history. If you're taking a good history, you will reach for, of course, for the diagnosis. The history is the cornerstone for epilepsy diagnosis, and the most important person to be asked about that is the witness. He's the most important one. And if the event is videotaped, it will make that easy because you can analyze the event very well. Very important in the history to ask about if the onset is witnessed or not. Why? Because most of the time, when the child presented to the ER mentioned that he has generalized tonic-clonic seizure, for example. But if you ask the parents if they attend the witness, if they attend the onset, if they attend the onset, may it focal then generalized. So it's very important to ask if they attend or witness the onset or no. And always we have to ask about before, during, and after the event. Asking about what? Asking about the predisposing factors. If there is family history, or if there is a precipitating event like trauma, fever, it may change the diagnosis. Ask about the pre-ictal semiology. If there is any aura, any behavioral change, automatism, tiredness, irritability, and etc. Then we go to ask about the ictal vase or the semiology. And very important to mention that in order, in a chronological order. First of all, occurring, for example, behavioral arrest, followed by, for example, left deviation of the eyes, and etc. So it's very important to mention it in the chronological sequence. If there is any motor activity or no, or non-motor, if there is any sensory abnormalities, for example, if there is autonomic features, and etc. So all of those questions under the umbrella of the ictal vase. Then we ask about the post-ictal semiology, if there is any sleepiness, confusion, headache, and etc. So the questions, in the common practice, always asking about the ictal phase only. The duration, so generalized myoclonic lasted for 5 minutes and full stop. But the correct way is asking about that, all the aspects of the event, because this will guiding me for the correct diagnosis. So if we have steps to go through to diagnose the epilepsy, we have to answer those 4 questions. Is it seizure or non-epileptic event? Number 1. If it's seizure, is it provoked or acute symptomatic versus unprovoked? If it's unprovoked, is the child has epilepsy or not? And finally, if he has epilepsy, what the type of epilepsy? We will go through it one by one. Okay, is it seizure or non-epileptic event? This is the most important question, I think, because it will avoid, if we master this question well, or the approach to this question well, we will avoid the misdiagnosis. Why? Because in the pediatric age group, we have a lot of seizure mimickers, and it's it's variable according to the age. The seizure mimickers in the neonatal age period, for example, different than the seizure mimickers in the childhood or the late or early childhood. Some of them are most important than the seizure or the epilepsy itself, and it need more prompt diagnosis and intervention, like the cardiac. For example, this cardiac, if you missed it and treat the child as, for example, epilepsy, you will miss the more important diagnosis. The key, I think the key for diagnosis, the non-epileptic event is the triggers. Always ask, as we mentioned before, if there is any triggers or no, if there is fever and etc. Or the child is crying before that, or for example, it occurred after feeding. So very important to ask about the triggers. if we look to the studies, we will find that the misdiagnosis rate in the epilepsy is ranging from 4.6 to 30%. And in adult, they found that in the non-neurologists is more common than in neurologists, 19.3 versus 5.6%. Around a quarter of the children with first seizure found to have non-epileptic events, and this is interesting. And around 40% of patients referred to tertiary epilepsy center were found to not have epilepsy. Those numbers tell us that it's very important to differentiate between the non-epileptic versus the seizures. Why? Because the misdiagnosis. If we, for example, overdiagnose, for example, the child has non-epileptic event and we label the child has epilepsy. This may lead to unnecessary treatment and subsequently side effect of the treatment, stigma and restriction for that child, and actual diagnosis can be missed. As we mentioned, for example, if he had cardiac insult, it will be missed. If there is underdiagnosis, for example, he has epilepsy, but we not yet diagnose him or diagnose him in other disease, that will lead to potential for epilepsy treatment is missed. And subsequently, it may affect the development of the child by the time. And the misdiagnosis will lead to wrong investigations and the treatment and wrong information and the prognosis given for the parents. Why in the epilepsy usually the diagnosis can be difficult sometimes? Because it needs very good history taking. And I think all the physicians should be practicing that very well. It's not other chronological diseases. For example, in the diabetes, we take, for example, the blood sugar, and it can guide us for the diagnosis simply. But in the epilepsy, no single test can diagnose that. The non-epileptic sometimes even can overlap with the epileptic event. And sometimes we have a difficulty in diagnosing that. And also, EEG can mislead. For that can, for example, give us one spike while the child has no epilepsy, as we will see later. I have different videos. For example, if we can see that this video, this is a common consultation from the nursery units because of this shivering or tremor-like movement increase with the stimulating the child. And this is what's called jitterness. It's non-epileptic event, as we see it in the right upper lip. Another example, this child in the infant age group, okay, he presented with this event, bluish discoloration and stop talking and breathing. Okay, and stop talking and breathing and doing like this tonic movement. And the key for this abnormal movement is it always occurred after crying. So this is simply breath holding spell, and it's non-epileptic event. Okay. Another less common event, like this event, which is called the gratification disorder. And it's less common than the previous mentioned one, behavior rather than epileptic. Another one, okay, let me make it. Okay, another event, it occurred usually after feeding and followed by posturing of the back, okay? And this is most likely gastroesophageal reflux. So we have to ask always, is it occurred after feeding or no, especially in the infant age group. If we go to the childhood or the early childhood, we can see this suppressible, which is occurred in stereotypic. It can be suppressed and increase in the stress situation, and this is most likely has a tics disorder. So as we see in those examples, we have different seizure mimickers. All of those are non-epileptic, or all of those not need any treatment regarding the epilepsy wise. Okay, so the seizure mimickers, it's different according to the, as we mentioned, according to the age group. For example, in the neonatal and early infancy, we have, for example, a benign sleep myoclonus, jitterness, as we mentioned earlier, shuddering attack, breath holding spells, Sandy-Fire syndrome, and etc. In the childhood, we have stereotypes, for example, benign paroxysmal vertigo, self-stimulatory behavioral, and etc. In the childhood and adulthood, we have tics, sleep disorders, for example, narcolepsy. All of those can be seizure mimickers. At any age, we have the syncopal attacks, the long Q2 cardiac, also syncopal attack, and etc. So the message here, be careful when you label the child has epilepsy. Be careful. We have to exclude those non-epileptic events. So if it's seizure, if it's non-epileptic, if it's non-epileptic event, if it's seizure. The second question, is it provoked, acute symptomatic, or unprovoked? Provoked, I mean there is identifiable cause. For example, the child taking medication, okay, then after that he developing that seizure. So it can caused by toxins, drugs, metabolic factors, and the key for that, as the key for the epilepsy in general, is the history. Ask about if there is a history of ingestion, withdrawal of medication, or if the child has chronic medical illness. Those usually came with the semiology or came with generalized semiology rather than focal, those who came with a provoked. And the laboratory screening is very important to diagnose that, like toxicology screening. And it's mostly no prophylactic anti-epileptic drugs need for those children. This is an example of categories of toxins can cause a provoked seizure, like stimulants, for example, cocaine, amphetamine, cholinergic agents, like, for example, nicotine, glutamic agonist, GABA antagonists, like tramadol, and histamine antagonists, and adenosine antagonists. All of those can lead to provoked seizures. Acute symptomatic, that's another category. It's usually due to acute brain insult, like sinus infection, stroke, traumatic brain injury. In opposite to the provoked seizure, this can lead to focal rather than generalized, and also it can be associated with other neurological or focal neurological findings. Always treat the underlying disease, like sinus infection, for example. I have to treat it, okay? And it may need short-term anti-epileptic drugs, okay? So if it's a seizure, it's not non-epileptic. This is seizure, unprovoked seizure. So is the child has epilepsy or no? This is the third question. Very important. Sometimes the child came with a generalized tonic-clonic seizure, which is very obvious seizure, okay? But sometimes the child has prior events which is not witnessed by the parents. For example, the child has prior events of absence or brief myoclonic seizures. So it's very important to clarify and to ask specifically about that, okay? Of course, if the child is diagnosed with epilepsy, he needs prophylactic anti-epileptic drugs. But the question, when the child with unprovoked seizure can label as epilepsy, if he fulfill one of those points, he have at least 2 unprovoked seizures within occurred more than 24 hours interval, 1 unprovoked seizure, and the probability of further seizure similar to general recurrence risk around 60% or more, over the subsequent 10 years after to an unprovoked seizure, or he fulfilled the diagnosis of epileptic syndromes. If the child has any one of those, so the child has epilepsy rather than just seizure. The fourth question, now the child has epilepsy. Which type of epilepsy? I have to categorize the seizure type, the epilepsy type, and if it under the umbrella of epilepsy syndrome. The seizure type, either we have, this is according to the International League Against Epilepsy classification, either it's focal, generalized, or unknown onset. Each one of those can be with motor component or with non-motor onset. And the focal can be with a preserved awareness or with impaired awareness. And also the focal can be secondary generalized or focal to bilateral tonic-clonic. So this is the how to categorize the seizures. So the child, I have to say, for example, he has generalized onset, generalized motor onset. What's the difference between them? The focus or the seizure, the focal seizure, it's arising only from confined area in the brain. But the generalized seizure is it's due to generalized synchronous firing activity in the brain. Let us take this example. Okay, so this seizure is generalized. This is generalized atonic seizure. So this is under the umbrella of generalized. Let us take this another one. Okay, this one has a brief shock-like abnormal movement, which is generalized. This is generalized myoclonic. So this is under the umbrella again of generalized. This is generalized myoclonic seizure. Okay, this gear, I will go on. Okay, so this girl, after the hyperventilation, she developed this seizure, which is absence seizure. Sometimes absence epilepsy can be confused with focal seizure with altered level of consciousness, which is occur with non-motor even. How to differentiate between them? The focal impaired awareness usually less than daily, or we can start with absence. Absence often daily, occur daily and multiple or many times, but usually the focal with impaired awareness less frequent than the absence. The duration usually for the focal, it's usually minutes, but usually for the absence, usually seconds. No post-ictal event in the absence. This is very important in opposite to the focal with impaired awareness. Also, the focal impaired awareness, it can associate with contralateral head or eye deviation, dystonic posture, but in the absence, usually it may have manual automatism, but usually it's less obvious than what occurred in the focal impaired awareness. So it's very important to differentiate between the two semiologies. Now, we mentioned the seizure type. Now we can, also we have to ask ourselves which epilepsy type this child have. If he has one or more type of generalized seizure, this is okay. This is called generalized epilepsy. For example, has absence and generalized tonic-clonic seizure. Okay, if he has one or more type of focal seizure, this is labeled as focal epilepsy. Sometimes the child has both generalized and focal. This is يعني The best example for that is Lennox-Gastaut syndrome. They have multiple seizure types, okay? And usually, if the child has both focal and generalized, usually they have drug-resistant epilepsy, or it can be unknown. So we categorize the seizure type and the epilepsy type. And this is an example, another example. Okay. Okay, this man, he has a drawing now. Okay. Okay. This example is very important. This sometimes which occurred usually in the AR. The mother sometimes come to the child while he is seizing in this point. Okay, when he is shouting and start to produce generalized tonic-clonic abnormal movements, and she mentioned that according to what she witnessed, he has generalized tonic-clonic seizure. But if we ask her, did you witness the onset or no? She will say, no, I did not attend the onset. So this is very important because if she attend the onset, it will be focal, started focal. After that, it's secondary generalized. So this is how the focal with secondary generalization occurred. After we categorize the seizure epilepsy, is it fulfill any epilepsy syndrome or no? What we mean by epilepsy syndrome? It's a clinical and EEG features very specific to that syndrome, and it's age dependent, and it may associate with development and epileptic encephalopathy. Idiopathic generalized epilepsies usually constitute 15 to 20% of all epilepsy, and it may have self-limited focal epilepsy like Rolandic epilepsy. We have a long list of epilepsy syndrome, either focal or generalized, or focal and generalized together, and developmental and epileptic encephalopathies. So all of those are example of, and because of the time, we cannot go one by one through it. So this is the scheme which each patient presented with seizure, we should answer those questions. What the type the seizure he has, what the type of epilepsy, if he has any epilepsy syndrome, and what the etiology of that, and if he has any comorbidities associated with the epilepsy. Now, we finished now the history, okay? We come to the further investigation. We have EEG, neuroimaging, and laboratory studies. Let's go with the EEG first. It's to monitor or monitoring a way to check for the electrical activity in the brain. So it's recommended in all children with first unprovoked seizure. Is normal EEG can exclude epilepsy? Of course, no. Normal EEG can never exclude epilepsy. 10 to 20% of patients with definitive epilepsy never have interictal discharge, okay? So if you have the reports from the neurophysiology department, this is normal EEG, it does not exclude epilepsy. In the opposite, for sometimes the interictal discharge can occur in healthy children, around 3.5 to 6.5%. So don't depend only on the EEG. No, depend on the clinical history or the history and physical examination. Then go for the EEG. The single EEG, as we mentioned earlier, the single EEG sometimes can fail to detect the interictal spikes. How to increase the yield of detecting the spikes? By repeating the study or record for longer period, and the seizure, if it's done within 24 hours of the seizure, the probability of detecting the spikes will be higher. It's indicated to confirm, not to diagnose. It confirms the clinical suspicion. So there is a clinical suspicion first, then it's confirmed by the EEG. And it assists the predicting the seizure recurrence. It's very important. Sometimes it can help in determining the type of the seizure and allow for the epilepsy syndrome diagnosis, like Rolandic epilepsy, for example. I diagnose it through the EEG. Assist for the choosing anti-epileptic medication, and in rare situation, it can help in the monitoring of the treatment of the epilepsy. This is very obvious in the infantile spasm. Is febrile seizure, headache, autism, ADHD, learning disability, psychiatric symptoms, is it indications for EEG? Mostly no. And also it's not indicated to exclude epilepsy diagnosis. For example, child came with migraine, very obvious migraine, he has headache. No, I want to exclude epilepsy. I will do EEG to exclude epilepsy. While that child, he has no events at all and no clinical suspicion of epilepsy. It did not necessary to do EEG. Neuroimaging, either structural or functional neuroimagings, usually it have high yield in children with first unprovoked seizure. Focal semiology and focal abnormalities, it increased the yield for doing اللي هو brain MRI specifically. The neuroimaging usually it's not diagnosing epilepsy, no, but it can help to reach for the etiology of epilepsy, in identifying, for example, structural cause and guiding the treatment and determine the prognosis and guiding for the genetic and metabolic testing and identify those who have potential for epilepsy surgery. Routine laboratory workup, usually when indicated for specific clinical circumstances. Lumbar puncture, only when there is suspicion of meningitis or encephalitis. Otherwise, it's not routinely done. But it should be considered in children younger than 6 months who came with seizure. Toxicology screen, not mandated in all cases, only if a clinical suspicion or suspected children. Autoimmune and genetic screening, not routinely done unless for a specific group of patients. The question now, treat or not, we have many principles for treatment. Usually we start or stop single drug. Mostly stop the treatment after 2 years. This is general rule, but it have exceptions. Blood concentrations, not always done blood concentration, only for specific medications. Medically resistance, if there is medical resistant epilepsies, we go for surgical evaluation. What's the medical resistance or medical refractory epilepsy? Failed of 2 anti-epileptic or more. And resolved epilepsy, it's another definition, which is age-dependent epilepsy syndrome, but now past the applicable age, seizure-free for 10 years, with no medications for the last 5 years. Recurrence risk, and this is very important. After the first unprovoked, around 33%. After the second, it's 76%. And that's why we are not treating usually after the first unprovoked seizure, because the recurrence risk is low, okay? But what are the factors can increase that percentage? If there is a prior brain lesion, if there is epileptiform EEG abnormality, if there is significant brain imaging abnormality, and if there is nocturnal seizure. This may increase the risk of the recurrence. Okay, and this is the final slide. If we have a patient came with seizure and history and physical examination, first, if it's non-epileptic, so I will refer the child at that specialty. For example, if he came with cardiac, I will refer him for the cardiology for that. If it first febrile seizure, is it a status? Okay, if it's status, I will treat it as a status epilepsy. If it's no, I will do the baseline with normal exam. If the patient has a baseline with normal exam, if he not returned to the normal, I will go for the further workup based on the clinical presentation. If yes, if younger than 6 months, I will admit and observe. If no, I will give outpatient EEG and MRI. If the history and diagnostic study suggests more than 60% seizure recurrence for that child, I will initiate an anti-epileptic medication. If no, I will monitor clinically. And if it occurred again, I will start an anti-epileptic based on the definition of International League Against Epilepsy. Okay, so we are done. And thank you again. And good luck.
Thank you very much, Dr. Muhammad, for this extensive approach to afebrile convulsions. I think we have about a few minutes for questions. If there is any questions, I can see you can write it actually in the notes, of course. There is any questions, Dr. Muhammad? Maybe I can ask Dr. Muhammad regarding treatment of the first seizure. What do we usually tell the parents or the patients regarding when they have first seizures? What is the risk for recurrence of this seizure for this patient to have a second seizure?
Okay, so if they presented with a first seizure, the risk of recurrence after the first one will be around 33%. So because of the risk of recurrence is low than the seizure will not occur again. So usually we are treating after the second seizure, except for a few exceptions for that. So usually with the first seizure, the risk of recurrence will be low. We will not start the treatment, but if it occurred again, after the second seizure, the frank seizure, I mean, no, okay, we will start the treatment for them.
And the percentage of having another seizure?
The percentage will be around 33%.
Excellent.
You will have another seizure.
Thank you.
If it occurred, the second one, the percentage of recurrence will be around 75-70%.
Okay. Thank you. Any questions? There is a question here from Dr. Fatima. If the patient is less than 6 months presented with afebrile seizure, should we treat or not?
If he came with first afebrile seizure, usually this is the first onset seizure. So usually we will not treat as it by definition, okay? But the workup will be different. Younger than 6 months, he had to be admitted, lumbar puncture, and etc., and treat if there is any underlying infection or provocating for that. But usually the risk of recurrence will be around 33%, so I will not start the treatment.
Thank you. Any other questions? Well, thank you very much, Dr. Muhammad. And we'll move to the next speaker, Dr. Afnan.
أيوة السلام عليكم. Next speaker is Dr. Aqila Al-Hashim, and it's my pleasure to introduce Dr. Aqila. Dr. Aqila, she finished her medical school at King Faisal University. Then she completed her Saudi board pediatric and also Canadian one. Then she did her fellowship as a neurogenetic. She had received many awards and honor, and currently she works as a consultant pediatric neurology and neurogeneticist at King Fahd Medical City in Riyadh, and also as a chairperson of medical staff peer review committee as a National Neuroscience Institute in King Fahd Medical City. Dr. Aqila, please start. She will present paroxysmal event.
Aqil, if you put the slide on the viewer as a full screen. Dr. Aqil, you're muted.
Okay.
Yeah. Now it's okay.
Okay, but is my screen, do you see my screen?
Can you put it in the viewer as a full screen, please?
Not sure what happened. Okay, so I'm just gonna share again. So do you see my screen now?
Yeah, that's fine. Now it's okay. Go ahead, please.
Okay, sorry for that. So we'll start, I'll discuss today paroxysmal events, and this topic is very important. You'll see why in the upcoming slides. As you know, lots of paroxysmal non-epileptic events, they can mimic serious issues, they can mimic epilepsy, and parents can be really concerned, especially in very young children, with the paroxysmal event, and the general pediatrician or general practitioner as well can be concerned. And lots of those, if they are not recognized, can be misdiagnosed as epilepsy, and some patients, they can be treated or have extensive investigation, which is unnecessary. And those paroxysmal events are common, especially in the first year of life. In one study, it has been found around 8.9% of paroxysmal events it happen in the first year of life. And sometimes it can be difficult to differentiate between those paroxysmal events and epilepsy, but the key to diagnose those is really having detailed history. So detailed history, as we always say in pediatric neurology, is the key. And here in particularly, it's very important from the beginning, how the event started, what was the patient doing, how did it end, and if the patients have, or the family have video, that will be very helpful. So we'll cover a few of those, the commonest paroxysmal events, and we'll describe them, and I'll show some videos. And as I mentioned, it's very important to know about those and take detailed history to identify them. So the first one is benign neonatal or infantile sleep myoclonus, and this usually occurs, as you know, during the sleep, and it's usually ceased after awakening. It's not uncommon. In one study, it has been found around up to 3 in 1,000 newborn, they have the benign neonatal myoclonus. The age ranges from few days into 6 months of life, but the majority after 3 months of life, they stop having those. And if you do EEG for them, the EEG is usually normal. So EEG is not necessary in those patients. If you see them and you identify this is benign neonatal myoclonus, the baby is otherwise healthy, you don't need to investigate. However, in a very rare occurrence, those sometimes can be atypical or very prolonged or severe. And to differentiate between just the myoclonus, which is not cortical, from epileptic myoclonus, which is cortical, EEG would be helpful in those cases. But as I mentioned, it's not indicated in the classic ones. The myoclonus itself, it can be symmetric or it can be asymmetric, and it can involve one limb and or different multiple limbs at a time. As I mentioned, differentiation with epileptic myoclonus, this is strictly usually happen at night. They do not happen during awakening. So if you have events during wakefulness, you would question that. You would think more that this is most likely pathologic. And the other thing, if you have severe episodes, the patient, especially if you have a sick patient with HIE, so those patients with HIE, they can have epileptic myoclonus, certain condition like non-ketotic hyperglycemia, they can have as well epileptic myoclonus, and the EEG will be abnormal. So I'll show you a video of the benign neonatal myoclonus. This video has been taken from YouTube, so it's public. And see the events that we were describing. It's just myoclonic jerk, and it's involving all limbs, but then you will see that it's more on the left, then can involve 3 limbs. So very quick, the baby is asleep. So this is very characteristic of the classic benign. So the terminology is benign, and everybody believes it's benign. However, there are some studies which showed a linkage between benign neonatal myoclonus and some, when they followed those patients till they become into childhood period, they found that there is migraine. Some of those children developed migraine, and there was strong family history of migraine among the family of those affected babies. So this is something found in a study, and it could be related, we don't know. The other condition that's very common is jitterness, and jitterness basically it's just a tremor, and it's recurrent rhythmic involuntary oscillatory movements. And it's very common. And in one study, it was estimated to be around 40% or 44% of healthy term babies. They can have jitterness at one point. And it's considered physiological. However, if you have a sick newborn, especially in the nursery or in ICU, you need to exclude as well if there is underlying electrolyte disturbance, because that can exacerbate the jitterness or provoke it, metabolic abnormality or thyroid issue. And there has been a study which linked jitterness, shuddering episodes into as early as sign of vitamin deficiency. So it's usually fine a tremor. However, if you have a coarse tremor, then you should think more of pathologic condition. And the differentiation between jitterness and epileptic phenomena, you will see in the upcoming video. So a tremor, usually with those jitterness, you can stop it whenever you hold, whenever you touch the limb, or even do flexion of the limb. While in epilepsy, you can't stop it. So see this video. This is again taken from YouTube. The moment, so this is tremor-like movement. It's very rhythmic. And whenever he touches the hand, it stops immediately. So that's the key. The other condition that's as well common paroxysmal event is shattering episode. And those usually happen in the first few years of life. It can happen several times per day, usually disappear in the first decade. And it's characterized by grimacing of the face and shaking of the upper extremity. I'll show you the video. This is again taken from YouTube, very illustrative. And I found this description that kind of fits nicely, that see how the baby is grimacing and shivering the upper extremity. It's like if you put an ice cube in the back of the baby, you would expect this reaction. So it's kind of, I like this description. It makes sense with the what the baby is doing. So as you can see, the baby is, or this child is conscious, completely conscious, but she's doing those and then can be snapped out of it. So consciousness is preserved, and this is a key. The other condition that's it's not super common, but it's important to know about it, is paroxysmal tonic upgaze. And in this condition, the eyeballs, they slide upward slightly and then come back. And again, the patient is otherwise fully conscious. There is no other associated movement with it, and it's considered benign, and usually it remits and resolves spontaneously. There are some studies, when they followed those patients, they found that around 30% or 40% they have some learning issues later on, and other studies found that around cognitive deficit in 10%. So if you diagnose this condition, please follow those patients up. Do not discharge them because this is kind of benign condition, because they might have associated abnormalities in the future. And some of them, not all of them, but it's worth following those up. And unfortunately, I don't have a great video. So this video you will see, it's subtle. So she have occasionally this gazing, and then she comes back. And as you see, she's otherwise happy child. Consciousness is reserved. It's very subtle. Okay, the other disorder is, it has different names, called infantile gratification disorder. Other name for it, previously it used to be called infantile masturbation, and another name as well, infantile, or not necessarily infantile, but a self-stimulatory disorder. So it's a stereotypic movement, basically. It's a kind of stereotypy, and those can last from minutes into hours. The typical age between 3 months to 3 years, but we have seen it in older as well kids, especially with children with intellectual disability. And those movement, it's basically, it happens, and I'll show you a video. It happens when the kids, they are in prone position, and their legs rubbing each other. There is some sort of stimulation in their genitalia, and they do have those autonomic manifestation with flushing of their face, sweating, and moaning or wheezing, and consciousness is not altered, is preserved. And when the family call the child, they can snap him out of it. And basically what you need to do is just to reassure the family that there's this is something kind of stereotypy, and it will resolve in the future as the child gets older. The majority of children that I've seen with this, they're usually intellectually disabled. However, it can happen as well in normal kids. And I'll open the sounds for this. I don't know if you, okay. So this is C, that kind of legs touching each other, and she's having this movement, but when her mom called her, she responded immediately. And it's kind of stiffened the legs, and this is, I couldn't find, again, one with this, with all the feature, but this is basically the posture that happen when they have the movement. And usually the child will go into a place kind of before they, some of them before they go into sleep, and when they are alone, they will do that. But again, the more they grow older and they are become aware, this will resolve. Myoclonus, as you know, myoclonus can generate from any part of the brain. To basically prove the origin of the myoclonus, EEG and EMG study can be helpful if you want to know where is this myoclonus coming from. So the myoclonus, the one as a paroxysmal event, basically is, we're considering the subcortical myoclonus, okay? The cortical myoclonus, as I mentioned earlier, when we talk about cortical origin myoclonus, this means that we're talking about epileptic myoclonus, and which is completely different thing. And epileptic myoclonus, as you know, especially in very young, can happen with early myoclonic encephalopathy, and the non-epileptic myoclonus pathological can happen as well in HIE, in IVH, and glycine encephalopathy. So be aware that myoclonus can be subcortical in origin, and it can be physiologic, or it can be pathologic in kids with having abnormal brain or having underlying neurogenetic condition. The other condition that's considered one of the paroxysmal event, and it's not common, but it's very important to know about this disorder, is hyper-equiplexia. And hyper-equiplexia is inherited. It can be inherited, or it can be sporadic neurologic disorder. And it's characterized by exaggerated startle reflex that might occur in response to a variety of different stimuli. So it's basically the child is having excessive startle response. Whenever they touch him, whenever he hear a sound, he will startle. And there are different forms. There is this trend, minor form, where there is kind of startle and tonic spasms after that, and in between the child is okay. But there is the major form where there is the startles and the examination of the child in between. There is some muscle rigidity that can happen in the first year of life, in addition to the nocturnal myoclonus, and that's considered the major form. So nose tapping is very helpful because to establish the diagnosis. You can find children with startle, and that can be normal. With hyper-equiplexia, whenever you do nose tapping, because this is basically a stimuli, you are stimulating them, this will happen. While in normal kids, even if those who have excessive startle, if you do frequent nose tapping, there will be habituation. So with habituation, what happened is there will be diminished response eventually, and the child will stop having startle reflex. While in hyperepilepsy, because it's not normal condition, and they have a mutation in a glutamate receptor alpha 1. So whenever you do nose tapping, they will have the startle reflex. There is no habituation at all, and that will be a clue to diagnosis. EEG in those kids, they're usually normal, and treatment, clonazepam can be helpful. Those patients, they are at risk of having apneas, so they need to be monitored for apnea and at home, because having apnea, especially at night, can be associated with sudden infant death syndrome. The other thing, if they have an episode of apnea, and you want to stop the episode, you can do that with rapid flexion of the head and lower extremity together. So you flex the lower extremity, you flex the head, and in order to stop an episode. So it's very important to know about this condition, because as I mentioned, can be associated with apneas, and that can be really life-threatening. I'll show you a video for this patient. See, whenever they touch him, he will have, with every single touch. So coming to summary of the common paroxysmal events by age, with a newborn, the commonest is jitteriness, benign sleep myoclonus, hyperepilepsy. It's not common, but it's basically mainly in a newborn. With infancy and toddler, you can have stereotypes, shuddering attack, breath holding spells. We did not cover, but it's very common, and you need to know about the cyanotic spells and the pallid spells, very important. And infantile gratification, or childhood self-stimulatory disorder as well, we covered that. Adolescent, they can have different paroxysmal episode, like syncope, migraine, can be an episodic, and can be associated with as well visual phenomena, and it can mimic epilepsy. So all those events, very important to know about. Some of those conditions with the epileptic condition, they imitate, for example, syncope with loss of consciousness can imitate different kind of seizures. Breath holding spells, especially when they are sanos and they are stiffening up, they that can imitate tonic spasms. Sandifer syndrome, which is related to severe gastroesophageal reflux, where the child in oxytonous position can imitate spasms. Benign sleep myoclonus can imitate myoclonic seizures or vocal seizures. Sleep disorders, we did not, it's a huge issue. There is no way we can cover it, but it can imitate different epilepsy syndromes. And migraine, as we mentioned, sometimes migraine with aura can have visual phenomena, so it can imitate occipital or temporal lobe epilepsy. So coming to the final slide, differentiation between paroxysmal event from non-epileptic or basically paroxysmal non-epileptic from epileptic event is very important. And the key to that is detailed history. And usually I tell my residents, especially when they take history for any episodic event, whether it's epilepsy or non-epilepsy, imagine that you are an investigator in a crime scene and you want to know really the detail of the scene, when this event started, what is the scenario, what was the patient doing, everything around that. You want to take that visual imagination of the event. That's how would help you to reach the accurate diagnosis. And having now everybody with their cell phone, if they can take a video of the event, that will be even better. So as I mentioned, accurate diagnosis is very crucial because lots of kids unfortunately ended up being treated with anti-epileptic medication, which is unnecessary for those events, or had extensive investigation, and the family were very anxious about the misdiagnosis, and that could have been prevented basically by labeling the child or having accurate diagnosis for the child. And as I mentioned, majority of those, the diagnostic workup is not required, rarely in some cases, which is atypical. Some patients, they might end up like in for a prolonged EEG monitor, or just to differentiate. And sometimes that's necessary if you have atypical case. So that's basically it. Thank you so much for being a great listener. If you have any question, please ask.
Thank you so much, Dr. Aqila, for excellent presentation. I think we leave the question at the end. Now, Dr. Samir, can you present the next speaker?
Yeah. Hi, it's my pleasure to present Dr. Rahman Bamaga. She graduated from King Abdulaziz University. Then she finished her general pediatric board training programming at King Fahd Military Hospital in Jeddah. Then she completed her fellowship in pediatric neurology in King Faisal Specialist Hospital in Jeddah. Currently, she is working as consultant of pediatrics and pediatric neurology in King Fahd Armed Forces Hospital in Jeddah. It's a pleasure to have you, Dr. Hannah.
Assalamu alaikum. Good morning, everyone. I'm sorry, I'm trying to share my screen, but I think Dr. Aqila, she has to remove her presentation first. Hello. Assalamu alaikum. Is it obvious?
We can hear you. Yeah, clear.
You can see it? Okay. Assalamu alaikum. It's my pleasure to participate in this very precious mini symposium that was organized by Dr. Afnan and the organizing committee. So after this brief and impressive two presentation preceded by Dr. Salumi and Dr. Aqila, my part will emphasize mainly about the anti-seizure medication. The main two questions that we face always is when and what to start. So at the top overview, it's mainly about those 2 points. When to start the treatment and which drug to start. And if the time allow us, maybe we can talk very briefly about the discontinuation of the anti-epileptic medication. So the anti-epileptic medication are known also as anti-seizure medication, anti-convulsant medication, but eventually they are describing the same group of medications. So when to start the treatment, the main steps that mentioned before about the history and differentiating between paroxysmal, epileptic, and non-epileptic is very important for this point, is to reach the correct diagnosis so you can start the treatment or not to start the treatment. It depends on the correct diagnosis that we have to reach. And generally, the start of the medication usually after the second unprovoked seizure. So basically, the first unprovoked seizure is a seizure or flurry of seizures or cluster of seizures occurring in the 24 hours in a person more than an age of 1 month. And epilepsy, as doctors previously mentioned, that it's diagnosed as 2 or more epileptic seizures occur unprovoked by any immediately infundable causes. So also this slide was described before about the definition of epilepsy by the International League Against Epilepsy. The definition of epilepsy is a person considered to have epilepsy if they meet any of these following conditions: at least 2 unprovoked or reflex seizures occurring greater than 24 hours apart, 1 unprovoked seizure, and a probability of further seizures similar to general recurrence at least 60% after 2 unprovoked seizures occurring over the next coming 10 years, and the diagnosis of an epilepsy syndrome. So the very important question that we have to ask ourselves and the one who referred the patient to us is about are the seizures not already recurrent? Because usually we know there is some types of seizure can be recurrent unnoticed and unwitnessed. The other things, are they caused by a progressive neurological disorder? And lastly is, they are a response of a normal brain to an abnormal condition, that we mean that acute symptomatic seizures. So the recurrence risk for those patients who present with seizure, usually we find that almost like more than 75% of those patients present with seizure, they have previous unwitnessed or unrecognized seizures. Mainly those patients with absence epilepsy, myoclonic seizures, patients with partial seizure without secondary generalization. The recurrence rate after the first seizure is estimated to be approximately 30 to 40%. And after the second seizure, it's about 70%. We have to know that the recurrence risk is higher among those patients with a remote symptomatic etiology, and for those who experience a second seizure within six months of first seizure. For example, those patients with hypoxic ischemic encephalopathy, asphyxia, those patients are under the higher risk for the recurrence. So what is the indications to consider anti-epileptic drugs treatment after the first seizure? We said before that usually we start the anti-epileptic medication after the second unprovoked seizure, but there is some exceptions and risk that we have to consider it before we delay and wait for the second attack. The high risk of recurrence, usually if we did by any chance an EEG after the first seizure and we found the EEG is abnormal, if we found there is any abnormal neurological status, neurological deficit, especially for those patients suspected to have like neurodegenerative brain disorder, who have like previous history of hypoxic ischemic encephalopathy, and if there was a prior seizures previously unreported. Because usually we sometimes receive patients presented with the first attack of generalized tonic-clonic, but if you dig more in the history, the family, they will describe some behavioral arrest, which is absence epilepsy. Some of them, they will describe like jerky movement was witnessed mainly in the morning for the last period last year, but this is the first time to present with generalized tonic-clonic. So those usually, they are unwitnessed or unrecognized by the family. They didn't think about that it's a seizure, sorry. So the other things, the possibility of partial seizure with remote symptomatic etiology, because also, as I mentioned before, that partial seizure can be sometimes unwitnessed or unrecognized because they are very brief, very short period. Sometimes they don't have any post-ictal events, so they can maybe unrecognized or unwitnessed. And also the high risk of recurrence is high in the first seizure during sleep. So the recurrence risk maybe reach up to 60% to recur if the first attack was during sleep. and also the adolescent onset seizures with a high risk of recurrence. If we put in our mind also the higher risk of injury with recurrence, so those patients with osteoporosis, a patient under anticoagulant treatment, patients who's having problems with the bleeding tendency, those patients who are old in age and elderly living alone, they are also at a higher risk of injury if they have a recurrence attack without any medical care. Also, if we consider the high risk of complication with recurrence, like for example, a patient with first seizures presented as status epilepticus. So sometimes we can weigh the benefit against if we want to treat or not to treat, because maybe the other attack will happen also as first attack as a status epilepticus, and this will end in a very complicated case control. Also, we have to consider the socioeconomic reasons. So this is mainly for maybe adults more than the pediatric age group. If the patient is employed, if he's driving, sometimes affecting the school performance. So that's that time we have to consider sometimes to start the anti-epileptic medications. So what is the factors associated with a lower risk of recurrence? As we mentioned, there is a higher risk of recurrence. Those patients also have a risk of recurrence, but they are lower risk of recurrence compared to the previous groups that as described. Seizures occurs within the 3rd month after acute insult, head injury or stroke. They have like a risk of recurrence, but they are lower than the previous groups. And alcohol withdrawal also can occur in the risk of the recurrence. So before we start any anti-epileptic medication, before we start to counsel the family, before we start our clinic, we have to put those points that I will present later in those slides in our minds. And we have to think about it before jumping and considering starting anti-epileptics. We have to know that the anti-epileptic drug treatment should be withheld from the most children until they have had a second seizure. But this is an we have to exceptions for those patients with a risk of recurrence. We have not to overestimate the risk of seizure recurrence. Also, we shouldn't underestimate the stigma of epilepsy, because labeling a patient as epilepsy and he's having not, and if he's not covering the criteria for the diagnosis of epilepsy, this will put a very bad burden and psychological burden on the patient and his family. In addition, the adverse effect of epilepsy treatment, we have to think about the side effects of the epilepsy treatment and weigh the benefit against starting or not to start anti-epileptic. And we have to know that the most children who receive anti-epileptic drug treatment should attempt to taper their medications after 2 years without seizures. So before starting the anti-epileptic, you have to put those points on your minds. Families' interpretation of probabilities and their views of the consequences of this risk and benefits vary widely. We face these issues of starting the anti-epileptic medications that the families, sometimes they are resisting, they have their own belief, they don't believe in the medications. So we have to know that sometimes we will face this resistance from the family, and not to be angry or upset, because eventually this is their kids, and they have to know what is the good from our point of view as a physician, and we have to discuss their concerns. And also we have to put in our mind there is a psychological, social, cultural resources and religious factors often overshadow the medical data. So at the first visit, if we have those patients who came with the first attack of epilepsy, we have to know exactly the nature of the disease, the prognostic implications, the objectives of the therapy. We have to discuss this point with the family, the risk and benefits of the treatment, the alternative therapeutic strategies. We have to counsel them about the school performance, swimming, driving, and regulations. Also, we have to discuss with them the psychological and social support for those targeted patients. So about the anti-epileptic medications, we have also to explain to the family that usually the anti-epileptic medication don't cure epilepsy, but rather attempts to prevent seizures. And they are also do not alter the underlying problem predisposing to the seizure. For example, those patients who's having like hypoxic ischemic encephalopathy with those presented with seizure, you have to explain to the family this medication is only to prevent and to help to avoid the recurrence for this seizure, but it will not treat the hypoxic ischemic encephalopathy in per se. And also we have to discuss the aim of decreasing the number, severity, and duration of the seizures. It's mainly focused on the point of complete seizure control without side effect to ensure the optimal quality of life. And while seizure freedom is ideal outcome of treatment, seizures can still occur while taking anti-epileptic medications. So before starting the anti-epileptic medication, those points should be emphasized in front of the family. So the other part of the presentation or the question is about which drug we have to choose now for the seizure. If we are confirming that this is an epilepsy or we have to treat this seizures. So we have to know the coming point that the seizure, we have to know the seizure type. Is this is an specific epileptic syndrome? Is there is an EEG findings? Also, it depends on the age and sex. It also depends on the associated medical conditions, medications the child is taking, the potential side effects on quality of life, the medical experience of starting the anti-epileptic, and the regulatory aspects and the cost, case-by-case basis. The availability of the disease, can the family afford this medication, or we can choose a cheaper medication with the same efficacy. So this is very important to consider it before choosing the anti-epileptic medication. So the steps is the first things, as we mentioned, that to make the correct diagnosis of epilepsy, to classify the type of the seizure and the epilepsy. The last things is about classification is about the generalized seizure or focal seizure, which was mentioned before by Dr. Salumi. So choosing the anti-epileptic medications, as we mentioned, that depends on the type of the seizure and some specific epilepsy syndrome. It's very known to us that the patient with tonic seizure or atonic seizures, usually we will choose for them the broad spectrum, mainly valproic acid, rufinamide, clobazam also, and lamotrigine. Those patients who's having spasm, we can use for them ACTH and vigabatrin. Patient with absence, usually the first line is ethosuximide. A patient with atypical absence, we can use for them ethosuximide or broad spectrum. The patient with myoclonic seizure, we can use for them the broad spectrum, including valproic acid. Those patients with focal seizure, we can use for them as a first line the narrow spectrum medication like carbamazepine, oxcarbazepine. I will talk about this point in a better way for the next coming slides. So this is in another way that we can say that the medication that effective or possibly effective against all seizure types, we call them the broad spectrum medication. They are like mainly the valproic acid, Lamictal or lamotrigine, benzodiazepines, topiramate, levetiracetam. Those in the second arrow that the medication for all seizure types except absence epilepsy, they are mainly phenobarbital and primidone. The effective medication against partial and generalized tonic-clonic, carbamazepine can be also used, phenytoin, oxcarbazepine. Those are the most famous medication we use in the pediatric age group. And as I mentioned before, effectiveness against absence is mainly the first line in the ethosuximide. So as mentioned before, the epileptic syndrome, it's a cluster of description, depends on the age of onset, semiology, and type of seizure, EEG findings and neuroimaging findings, and clinical features, such as a loss of language. But I will not talk about this part because I want to mention it. So if we take it like, and I will talk only mainly about the most common epilepsy syndrome that we face in the maybe primary or secondary centers. So infantile spasm, usually the infantile spasm is a severe form of epilepsy that can lead to poor development and should be evaluated right away. So the first line and the preferable medication that we can use for them, steroids. ACTH, and also prednisolone. We can consider vigabatrin in those patients with tuberous sclerosis. Patients which diagnosed as juvenile myoclonic epilepsy, they are initially presented with absent seizure, later develop generalized tonic-clonic and myoclonus. Maybe we initially consider starting valproic acid or lamotrigine instead of ethosuxamide because they have like multiple type of seizure, absence and generalized tonic-clonic and myoclonus. If a clear diagnosis cannot be made, we can only use for them valproic acid and a broad spectrum anti-medication. And we have to avoid those medication. We can exacerbate the myoclonus, mainly carbamazepine, oxcarbazepine, and phenytoin. So as long as we have the first lines or the preferable medication to start to treat those patients with a specific syndrome, we have to know also the contraindicated medication. In absence epilepsy, the first line usually is ethosuxamide. Also, we can use a valproic acid and lamotrigine, but we have to avoid carbamazepine, oxcarbazepine, and phenobarbital because they also exacerbate the absence epilepsy. In patients with the diagnosis of benign epilepsy with centrotemporal spikes, which was known as Rolandic epilepsy, usually we don't treat those patients. But if the patients have the seizure during the day, if the seizure disrupts their sleep quality, also we can consider starting an anti-epileptic. And also if the patients start to have reading disabilities, we can start the anti-epileptic medication. The first line usually the narrow spectrum anti-epileptic, carbamazepine, oxcarbazepine, and we can use also levetiracetam. About the age, it's very important to consider the age also when start the anti-epileptic. So, for example, those patients younger than the 2 years of old, we have to avoid valproic acid due to the induced liver toxicity. Also, those patients will presented in a childhood age. We have to take care also in case if we start for them phenytoin because they have the tendency to develop the side effect of acne, hirsutism, gum hypertrophy, and coarse facial features. Regarding the choosing the anti-epileptic based on the sex preferability, usually we have to know that the valproic acid and lamotrigine can induce teratogenicity in childbearing age women. Also, some of the medication, they increase the metabolism of oral contraceptives by inducing enzyme effect, such as carbamazepine, oxcarbazepine, phenytoin, phenobarbital, primidone, and topiramate. And this is mainly for the maybe adolescent age group. We have to take care of those medication. There is some other medical conditions that can benefit from anti-epileptic medication. So, for example, if you have patient who's non-case of migraine, and he presented this time with the epilepsy, and you consider to start him with anti-epileptic medication, maybe you will choose a better medication that can treat both medical conditions, such as in the patient with migraine, valproic acid, topiramate, and gabapentin can be considered. Patients who's having psychological issues, they can get benefit of mood stabilizer like carbamazepine, oxcarbazepine, valproic acid, and lamotrigine. If we have patients with hepatic impairment, maybe we can use for them levetiracetam, gabapentin, and pregabalin because they don't affect their liver etiologies. If we have patients with a renal insufficiency and patients on dialysis, we have to take care and consider adjustment in the renal insufficiency for levetiracetam, gabapentin, and pregabalin. If we have patients with susceptibility of hypersensitivity or previous allergic reaction, we have to know that there is a higher risk of hypersensitivity for lamotrigine, carbamazepine, phenytoin, zonisamide, and phenobarbital. And it's worrisome because some of them, they can develop Stevens-Johnson syndrome. On the other hand, we can consider those medication as a lower risk of hypersensitivity, such as valproic acid, levetiracetam, gabapentin, pregabalin. Even though some of them they can like develop rash, but it's not like critical or life-threatening compared to the previous medications. So if we have a patient is overweight or obese, we have to avoid valproic acid, carbamazepine, gabapentin, and pregabalin due to the higher tendency of increased weight. Also, in patients with renal calculi, we have to avoid as a first line the topiramate and zonisamide. But maybe sometimes we consider it if we have like intractable epilepsy or difficult to control, but we have to put it as a last choice. Those medications are known as to be as a potential side effect of irritability and should be avoided in patients with ADHD, autism spectrum, aggressive children, and in children and adolescents as well. Phenobarbital and most commonly the levetiracetam. We have to avoid it as it causes irritability and aggressive behavior. In patients with depression, we have to avoid topiramate, phenobarbital, primidone, and vigabatrin. And as we know that also the lamotrigine can cause some kind of anxiety and insomnia, and we have to consider it in our mind if the patient is already having an anxiety disorder or is having sleeping disturbance. Avoidance of valproic acid should be in patients with mitochondrial disease, urea cycle defect, patient with profaria, and patient with hepatic and pancreatic disease due to the complication related to those medical condition. Also, we have to avoid valproic acid and vigabatrin in the patient with non-ketotic hyperglycemia, as they can exacerbate and put the patient in the worsening of their encephalopathy. The potential side effect on the quality of life, we have to consider those points that the patient taking the topiramate can be affected by the side effect of the topiramate, and that can affect their school performance. And they have difficulties mainly in words findings. They will develop poor concentration. Also, those patients who's attending the school or driving, we have to avoid the benzodiazepines and carbamazepines as they can cause sedative side effects. Those patients who's underweight or having problem with the feeding issues, we have to avoid topiramate as it causes anorexia and weight loss. The other things that we have to put in our point before choosing the anti-epileptic, we have to consider regularity and aspect and the cost. So for example, if we have patient with a focal seizure and we consider to start him with the narrow spectrum medication, we have to consider choosing carbamazepine or oxcarbazepine. And we have, usually we prefer them comparing between the 2 points, the efficacy and the cost. So if it was affordable or available, we can put like oxcarbazepine as like preferable medication compared to carbamazepine. On the other hand, also clobazam and clonazepam. Even though the clobazam is highly effective with a lower side effect, but sometimes it's not available in the hospital and it's costly in the private sector. So we can choose clonazepam. But if we can afford it and we can give it to our patient, we can consider clobazam as a first line. The other things that the accessibility to the hospital, some people, they cannot attend to the hospital to get their prescription of the control medications such as phenobarbital or clonazepam, either because there is no one can attend the hospital or they're living far away. So we have to put in our mind that we have to start medication that can be available in the private pharmacies, or they can buy it without a prescription. For example, levetiracetam, which is available everywhere. So the principles to follow when prescribing anti-epileptic, we have to start with a very low and slow to reduce or avoid the side effects. For example, allergic rash. The other things that the aiming of control seizure with one anti-epileptic medications, monotherapy, where it's possible. And we have to give the medication a good trial prior to work before changing. So if we have one patient who presented with epilepsy and we decide to start anti-epileptic, we have to start with a lower dose and very slow to avoid side effect of allergic reaction, for example, namitrogene. And in the other hand, we have to give the medication a good time to show us its efficacy, and not to rush to change the medication from medication because of like we're aiming to control the epilepsy or the seizure. So give it the good time, give it the medication the chance before jumping from medication to medication. So the other principle to follow when prescribing anti-epileptic medication is to recognize the doses and tolerance of anti-epileptic medications, that it's vary between individuals. Some of people, they can tolerate the side effects very easily. Some of them, they will develop the side effects very quickly with a smaller dose. So we have to know that there is a variation between the patients. And also we have to consider spacing medication doses appropriately to maintain the stable blood levels. I faces that some cases they will present with only OD dose of anti-epileptic, but we cannot consider it like it's a maintenance dose, because we have to ensure that the blood level is stable over like every 2 hours or Q8 hours, depending on the patient's situation. As well as we have to avoid the combination of the anti-epileptic medication that are known to interact with each other. So the effectiveness of the first anti-epileptic medication, usually the seizure-free for at least 1 year. If the first drug, they will reach it by almost like 47%. If we added a second drug with a monotherapy, it can be about up to 13%. If we added like a third drug monotherapy, will be decreased down to 1%. If we started with polytherapy of 2 drugs or more, the seizure-free for 1 year will be almost like around 3%. The other things that almost like 64% of the patient, they can reach medically controlled epilepsy, and almost like 36% of the patient, they will be refractory for the medical treatments. On the other hand, there is some seizure can be aggravated by anti-epileptic medication, and as I mentioned that in the most important epilepsy syndrome, but this is a summary for those medication. As I mentioned before, myoclonus and absence can be exacerbated by carbamazepine and phenytoin. Patients with absence epilepsy also sometimes they can develop for a generalized tonic-clonic if we consider or start with a carbamazepine. Patient with myoclonus can get worsening if we start those patients with the benzodiazepines. So we have to consider the side effect and the contraindication before starting the anti-epileptic. So before we assume that the seizures are aggravated by the anti-epileptic medication, we have to think about those points, because sometimes you are sure that you started the appropriate anti-epileptic medication, but the patient is presented with a worsening of his seizure, not getting any benefit of anti-epileptic medication, and there is no control of seizure. So it could be the fluctuation and the need to be adequate baseline frequency. I mean that the patient's having, this is natural history of his disease, that his seizure will get worse. Also, we have to rule out any seizure aggravators, sleep deprivation, and alcohol before considering this patient is resisting this anti-epileptic. Also, we have to dig and ask about any medical condition or any medication used with this anti-epileptic medication in the same time due to the drug interactions, which lower the level of baseline effective treatment dose. Also, we have to ask about the compliance. So some of the people, they don't comply on the medication, and they will present to us with the exacerbation of seizure. And if you ask them in the history, they will tell you that they're skipping medication, they didn't refill their medications. Also, some consider that like overdose of carbamazepine can cause increased seizure. Maybe the patient will present as a side effect of carbamazepine or carbazepine by developing hyponatremia. So he will present with seizure, but it's a symptomatic seizure and it's not a part of their epilepsy. As I mentioned before, the drug interaction also can cause the exacerbation of seizure. So if it's possible, continue anti-epileptic medication until it's clear that the seizure increases is not transient. So don't jump to change the anti-epileptic medication and switch from medication to medication until you are sure 100% this exacerbation is not due to one of those previous points I mentioned. So at the end, I hope the time that allow us, I will just talk briefly about consideration of discontinuation of anti-epileptic medication. We have to put in our mind that the longer is the remission is the less likely is subsequent to recurrence. So usually don't think about discontinue the anti-epileptic before 2 years of seizure-free period. And we have to explain to the family, they have to write the date and to be sure from the exact date of the last seizure, not from the initiation of anti-epileptic. Yes,
do you have like two more minutes?
Okay, خلاص, it's only one slide. So we have also to slowly withdraw those medication, especially the benzodiazepines medications. So this is briefly the factors affecting the risk of relapse after the anti-epileptic medication duration, discontinuation, short duration of seizure freedom prior to drug withdrawal. For example, I saw some of them, they will they see the anti-epileptic after 1 year. So this patient will have higher recurrence of their seizure after withdrawing. Epilepsy with onset of the adolescent or adulthood, remote symptomatic epilepsy, patient with the myoclonic seizures and mainly juvenile myoclonic epilepsy with need lifelong medication, multiple seizures type, and previous failed attempts to stop medications. Also, the prolonged period before achieving seizure control, seizure while on treatment, seizure control requiring multiple drug therapy if there is abnormal findings of EEG, even after the completion of 2 years of freedom, if the patient having learning disability and associated neurological disease. So the outcome is a greater psychological impact of seizure relapse in adults more than the children. Most of self-remission epileptic syndromes are in childhood. They will remit and resolve on its own, not mainly from the completion of anti-epileptic. We have a higher tendency to withdraw medication for those patients with a mild brief focal seizure. Nocturnal occurrence is preferable to discontinue. At the last, if seizure recur after the anti-epileptic medication discontinuation, reinstitution of treatment lead to a good outcome, and almost like 90% of those patients attain another 2 years of remission. Thank you.
Thank you so much, Dr. Hanan. Back to you, Dr. Afnan.
Thank you, Dr. Hanan. The next speaker is Dr. Shahada Shafi, who is graduated from Al Qura University after completed her medical school. She joined the pediatric neurology residency program. Then lastly, she went to Canada to do her fellowship, clinical fellowship in pediatric epilepsy. And currently she is pediatric neurology consultant and epileptologist in Prince Sultan Medical Military Hospital. She will present neonatal seizure. Please, Dr. Rashada.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. Afnan, for this introduction. And I would like to thank the organizer committee and scientific committee for this invitation. My topic today is about neonatal seizure overview. I hope to cover it on the coming 30 minutes. This is my outlines. So neonatal seizures, it is a medical emergency and indicate a potential treatable etiology that requires a prompt immediate evaluation and determine the cause, which can influence the future of the newborn. It is clinically described as abnormal and stereotyped paroxysmal dysfunction of the central nervous system that happen in the first 28 days after birth in term infant and before 44 weeks in preterm infant. Seizure is quite often in neonatal period, especially in the first week of life, more than any other period in lifespan, as you can see. The incidence, it's around 1 to 5 per 1,000 and 1 to 100 in 1,000 preterm. What is special about a neurophysiological change in newborn is that GABA is excitatory rather than inhibitory in perinatal neurons because of elevated neuronal chloride. Besides that, GABA-A receptor activation can lead to chloride efflux that lead to excitation rather than influx what lead to inhibition. This developmental change might explain the imperfect response of neonatal seizure to GABA antagonist anti-seizure medication. Neonatal seizure have a frequent clinical scenario, clinical manifestation in neonatal period that can present within a framework of 4 clinical scenarios. First, it's acute symptomatic seizure, or recently they call it preferred to be called as provoked seizures after an acute brain insult, and usually it happens within the 72 hours after birth. That it might have stopped for some time and have a latent period and to come back in a postnatal period with a postnatal epilepsy, or if the insult is quite severe, can lead to continue to be symptomatic epilepsy. And lastly, which is the least frequent type, it is neonatal epilepsy, which is the unprovoked type due to structural brain malformation or genetic cause. As I mentioned, 85% of neonatal seizure is due to an acute cause with different etiology. All of the neonatal seizure is a focal onset, and the new classification of neonatal seizure either electroclinical or electrographic. The most common cause of neonatal seizure, it is hypoxic ischemic encephalopathy, followed by infarction and hemorrhage. Genetic epilepsy, around 10% of the cases. Seizure in hypoxic ischemic patient, it is really quite frequent. In this study, it is 50%, around 50%. However, in other studies, it's up to 80%. And most of these seizures in hypoxic ischemic setting, it is electrographic. I would like to really encourage you to read this newly published paper by the ILAE, the classification and definition of epileptic syndromes in neonates. It's really a detailed paper of each one type of epileptic syndrome. So what is epileptic syndrome? It is like a cluster of clinical signs and symptoms that have special type of seizures, age of onset, etiology. They have similarity in the EEGs and a response to anti-epileptic medication. It is really quite rare in pediatric age group. In this paper, it is around like 13%, like they study around 600 of newborn with seizures. 79 of them, they having epileptic neonatal epilepsy. Half of these, it is neonatal epileptic encephalopathy, and around 14%, it is benign familial neonatal epilepsy. When to suspect metabolic defect or genetic epilepsy, when you have unremarkable birth history, when you have a positive family history or other involvement. It is when you have a specific type of semiology. In this nice paper, you can see in hypoxic ischemic encephalopathy, the main type of seizure, it is clonic or either electrographic. In stroke, it's clonic or electrographic. In the other type of seizure, like related to genetic epilepsy, it is either tonic or myoclonic seizure. So it is really the type of seizure play a prognostic type. Again, to our question, so when you suspected a genetic epilepsy or underlying metabolic, when you have refractory epilepsy not responding to conventional treatment, progressive deterioration in the level of consciousness of the patient, and when you have normal MRI of certain abnormality. This is a nice diagnostic framework with the new classification. So when you have a critically ill child, neonate, or suspected abnormal movement, you have to confirm it with video EEG. Video EEG, either it will have electroclinical or electrographic. In all the classification, there was clinical seizure. Now it is removed. The new classification of neonatal seizure, either motor, non-motor, sequential, or unclassified. So what's the meaning of electroclinical? It means clinical sign that is coupled with abnormal electrographic changes. Electrographic only seizure mean it is abnormal EEG meeting the criteria of electrographic, but have no clinical sign. And previously, they call it clinical only seizure. It means like a normal paroxysm of movement that have no definite EEG association, and they are not seizures. I will go through some of the videos. This video is from the internet, so it is okay to share it. First common type is focal clonic. It is repetitive contraction of muscle group of muscles. It could be unilateral, multifocal, synchronous, asynchronous. It is not suppressed by restraint, and most of the time it is epileptic. This is a multifocal. If you can concentrate here, you can see like the jerk rhythm here. It is really different from the upper limb. Focal tonic, it is a sustained contraction of single limb, usually associated with asymmetric posturing of the trunk with sustained eye deviation. Again, it is not provoked by stimulation, not suppressed by restraint, and it is epileptic. On the other hand, the generalized tonic, where there is a symmetric sustained in posturing of the limb, maybe flexor, extensor, maybe provoked by stimulation, maybe suppressed by restraint. It could be epileptic, and most of the time it's non-epileptic. Myoclonic seizures, it is rapid, single contractions of, So they are a single random contraction of muscles. It could be generalized focal symmetric, and it could be epileptic and non-epileptic. What about spasm? It is a sudden flexion or extensor. It cannot be provoked by stimulation, not suppressed by restraint, and most of the cases it is epileptic. What is sequential seizure? This is newly added in the new classification. It is a variety of clinical signs occurring in a sequence with individual seizure. It indicates change in lateralization within or between the seizures. So this is most commonly seen in genetic epilepsy. You can see this child, they have a different type of semiology between the seizures. Moving to the second type, it is the motor automatism. Most of if them, they are non-epileptic. They can associate with electroclinical. In this part, we really need EEG to confirm it. Example of them, it's ocular sign, like random or roving eye movement with nystagmus. And it could be provoked with stimulation. They presumed pathophysiology is non-epileptic. Buccal lingual movement, like chewing movement, may be provoked by stimulation, and again, presumed pathophysiology is non-epileptic. Progressive movement, like bicyclic movement or paddling, This could be provoked by stimulation, suppressed by restraint, and most of the cases they are non-epileptic. So in this table, you can see that these subtle movements have inconsistent EEG finding. On the other hand, most of what we describe, the clonic, tonic, myoclonic seizure, they have a consistent EEG changes. And this paragraph again, in this picture again, you can emphasize that most of the neonatal EEG seizure, it is electrographic, and around 70% it's electroclinical. So in critically ill neonate, they found around 1/3 of the case, they have electrographic seizure, and HIE cases, it's really very frequent, as we mentioned, up to 80%. We are talking here about the really is this seizure, it is harmful for the neonate? The question is yes, the answer is yes. Many evidence has showed that these seizures are really harmful for the neonate, and it is really affecting, it leads to morbidity, mortality, and increase imaging markers. They found in one study increased high lactate. So if you have any seizures that you do not really, a seizure that you did not confirm it by EEG, that you subsequently you will miss subclinical seizure, then the patient will receive an appropriate medication that leads to brain injury as well as systemic dysfunction. What about clinical diagnosis? Why it is clinical diagnosis? It is poor. In this nice study, they do the inter-observer agreement in neonatal seizure. They bring around 20 video clips. 11 of them, it's confirmed seizure, 9, it's not seizure, and they bring qualified doctor and nurses. There are like 100 of them, and only 50% of them, they have it right. And doctor is not better than the bedside nurses. This is again another study. They bring qualified nurses from and physician from the ICU, and they give them a videotapes. 78% of these paroxysmal events documented by them, they are not seizures. So clinical diagnosis is really difficult and unreliable. This leads to underestimation and overestimation, and this leads to over-treatment or under-treatment. Going to the differential diagnosis of neonatal seizure, you have to be familiar with jitteriness, which is really can stop with restraint, as you can see in this child. Again, when you hold it to stop, and with the stimulation, it will be aggravated. See when he touch him. Hold him again, stop, touching, it's coming back. So jitteriness, it is it's usually seen in the first few days of life and disappear in the second day. It is stimulus induced. Usually it's not associated with any abnormal eye gaze or autonomic change. If it's exaggerated, it means really to be investigated to rule out electrolyte imbalance, infection, and drug withdrawal. One of the differential diagnoses, it is REM eye movement in a newborn. You can see this random eye movement in a very normal child, and it's only during sleep. The second one also related to sleep, they call it sleep myoclonus. It is exclusively happen during sleep, and it disappears once the child aroused, provoked by rocking the patient. The child usually is very normal, and the trial of benzodiazepine, it's usually make the thing worse. This is a hyperepilepsia. It is stiff starter disease, or they call it congenital stiff man syndrome, associated with exaggerated starter response and sustained tonic spasm. You see, each time he touches his nose, he have this sustained tonic spasm. So to diagnose neonatal seizure, we need a video EEG. The electrographic neonatal seizure defined by the International League Against Epilepsy as electrographic event with an abnormal pattern, sudden, repetitive, evolving stereotype waves form with ending and beginning. The definition in the new paper, they eliminate the 10 second. It's only need a waveform that have an ending and the beginning and evolution. This is the most important thing. What is the indication to start continuous EEG? So to monitor the evolution of EEG background to assist the prognosis, to guide titration of anticonvulsant treatment, and screen of seizure in high-risk group. It is really required for any patient in paralytic agent to rule out any suspected event. As well, it can really detect any impending ischemia or hemorrhage. In this nice study, they bring around 500 neonates. 1/3 of them, they did screening EEG. What is the meaning of screening EEG? They did it only for indication of encephalopathy or the patient in paralytic agent without suspected seizure, or most of them confirmatory EEG means they put EEG when there is a suspicion of a seizure. They found that neonates with screening CEG have a high proportion of successful initial seizure treatment than neonates with confirmatory CEG by around 40 to 18% difference. When to stop CEG, the American Clinical Neurophysiology recommend monitoring for 24 hours, and if the interictal discharged and stable, interictal background, it's stable, and no seizure are recorded from the last seizure, should be continued for another 24 hours. Exception is children with hypoxic ischemic encephalopathy. They need to be monitored during cooling and rewarming, and for cases for paroxysmal event, it should be continued until you capture like severe event. This is an EEG for 4 days old full term who have hypoxic ischemic encephalopathy. You can see brief rhythmic discharges over the central head region. Subsequently, with a continuous EEG, he starts to have a prolonged EEG, subclinical seizure for around 40 seconds. The brief rhythmic discharges, they usually meet the seizure criteria, except for the duration. It's really associated with underlying pathology and indicate that there is a seizure is coming. When a bird associated with clinical manifestation, this means this is seizures. If we don't have continuous EEG, the alternative is the Amplitude Integrated Eeg. It is not equivalent to the conventional multi-channel EEG, but it's really useful with a variable sensitivity and specificity. This is the integrated EEG. You can see very nicely pick up the seizure. It is like elevation in the background, and this is how it's seen in the raw EEG. So as we mentioned, this have a very variable specificity and sensitivity because it is really a dependent reader. When it is not combined with the raw EEG, there will be an over-prediction of the seizure up to 100%, which is not good. This algorithm will determine the degree of diagnostic certainty for neonatal seizure. So if you have a seizure and you confirm it with CEG, this is the gold standard. But if you diagnosed it or correlated with AEEG, this is a probable diagnosis. But what if you don't have them, like the EEG, and you depend on observed experienced personnel? It depends on the type of the seizure. For focal or chronic seizure, it is probable, but any other type of seizure, it is possible only. So when you evaluate an neonatal seizure, it's really you need to dig much in the history, perinatal history, mother history, and family history. As well, there are a very detailed neurological examination and presence of organomegaly, and you have to stress on the skin, ophthalmic, and eye exam. What about the investigation? In this table, it's summarized the first test that to be done and the second. And in this algorithm, it is nicely prescribed. So when you have a patient after history and physical exam, you confirm it with EEG. The first workup, it includes basic examination, especially electrolyte, glucose, calcium, magnesium. You have to culture every fluid, the blood, CSF, and the urine. If it's abnormal, you have to proceed for neuroradiology. If it's normal, you have to make more extensive metabolic workup. MRI, it's really very useful. It can reach the diagnosis up to 60%, and other papers up to 90%. What if the MRI cannot be doable because the patient is not stable or for any other reason? CT scan and cranial ultrasound should be done, and it's really quite helpful to diagnose some of the underlying etiologies. Shifting now to the treatment of neonatal seizures. So treatment of neonatal seizure, it's really depends on three things. Number one, neuroprotective strategies and supportive measures like ABCs. Number two, it is etiological therapy. Number three, it is anti-seizure medications. So focusing in etiological therapy, which is correctable, treatable things, including neonatal encephalopathy, sinus affection, hypocalcemia, and hypomagnesemia, and then to consider inborn treatable condition where they are, in case of the patient is not responding to the first measures, you have to consider like pyridoxine-dependent epilepsy, phenolic acid, and pyrantinidase. This is a nice algorithm when you consider cofactor responsive neonatal seizures. Like when to treat, it is not only depending on a correct diagnosis, but they found that how much is the seizure burden. So brief seizure may not require treatment, but really need to initiate the EEG to evaluate the seizure burden. Some authors suggest that seizure burden more than 30 to 60 seconds per hour should indicate to start treatment. In terms of anti-seizure medication, really there is a paucity of high quality evidence for the first and the optimal first and second line, the dosage, and when to discontinue. And there is no a level 1 evidence to tell us if the treatment of neonatal seizure is really associated with the improved long-term outcome. However, there is clear evidence support that rapid and effective treatment of neonatal seizure, it is a standard of care. And to be honest, there is a broad agreement among institutional pathways. And I have to stress here what they found from evidence that standardization of care using a local management pathway will allow to focus on quality improvement and improve the treatment timelines and effective treatments and eventually discharge the patient. This is a very nice published paper recently where they do a comparison of the treatment pathway in 11 neonatal care units, a high level of neonatal units in the United States. And this is the summary of what they found. Most of the pathway, they give IV benzodiazepine administration if either the EEG or the loading of anti-seizure medication is delayed. All of them, they're giving phenobarbital as a first line. The second line, it's between phosphonitone, second and third line, it is between phosphonitone and levetiracetam, and all the pathways, they escalate to continuous midazolam infusions with variable dosing. Only 3 of the pathways include lidocaine infusion. 9 pathways discuss the anti-seizure medication discontinuation after resolution of acute symptomatic. In this paper, they did not talk about the adherence of these ICUs. They just discuss the pathways And this is the summary of which you can use it for a guideline in your local area. And you can see in the second line, it is split between phosphonatoin or levetiracetam, and then you alternate between them. And this is the doses that can be used in this study. Like this anti-seizure medication, they are not harmless, harmless medication. It is really associated with worse neurodevelopmental outcomes.
Dr. Shada, 5 minutes.
Okay, I'm almost done. When to stop the anti-epileptic medication? This is a new published paper. They talk about the safety of early discontinuation. Evidence support early discontinuation of anti-epileptic medication after acute symptomatic seizures. There is no clear rationale to keep the patient on maintenance, as there is no benefit on the neurodevelopment, and it's only expose the patient to a harmful medication, and it will not delay the onset of epilepsy. Now in the era of target epilepsy of epileptic syndromes, for example, in KCNQ2, we have to try the sodium channel blocker. In KCNT1, use quinidine, and again memantine. Lastly, we're talking about prognosis. They found that preterm infant are double the term infant in subclinical seizure, as well in the death mortality in preterm is 35, and the term is 15%. They found that around 50% of patients after neonatal seizure, they have neurodevelopmental abnormality and global developmental delay, and 1/3 of them, they will have epilepsy. In this nice paper, they found 3 risk factors that make early onset of epilepsy. First is the presence of 3 days of EEG seizures. Number 2, a very abnormal EEG background. Number 3 is abnormal neurological exam upon discharge. The risk of infantile spasm after neonatal seizure, it is around 6%. There's 3 risk factors in this paper for infantile spasm, including severe abnormal EEG or more than 3 days of seizure recorded, abnormal MRI, and abnormal tone. The presence of these 3 factors making the risk of the satisfied risk for infantile spasm up to 57%. I would like to thank you for my listening to my lecture, and my take-home message. The clinical identification of neonatal seizure is really difficult, but it's really needs early diagnosis and management. You have to be familiar with mimickers and treat underlying correctable cause. Really, we need to increase using continuous EEG, anti-seizure medication. It is not harmless medication. Evidence only we have that phenobarbital, it is the first choice of medication in neonatal seizure. Thank you very much.
Thank you, Dr. Shada, for this excellent presentation. Dr. Samir.
Yeah, and now it's my pleasure to present my colleague, Dr. Ahmed Bamaga. Dr. Ahmed, he graduated from King Abdulaziz University with honor. Then he joined the Hospital for Sick Children and did his pediatric neurology training, and then he joined University of Washington to complete his clinical fellowship in neuromuscular medicine and neuropathology. He will talk with us about altered level of consciousness. Mike is yours, Dr. Ahmed.
السلام عليكم، يعطيك العافية دكتور، الله يبارك فيك. الصوت واضح ولا؟ You guys hear me okay?
Yeah, we can hear you.
Good, okay. طيب يعطيكم العافية جميعا. So good morning everyone. Let me start by thanking the organizing committee for having me today. Hopefully we're not gonna, I'm the last one for this morning, so I know you guys are quite hungry, so will not take a lot of time. The morning was a lot of, was all mainly about seizure, so we're gonna shift gears a little bit. We'll talk about approach to altered level of consciousness. Hopefully we're not gonna take more than 30 minutes or so, then the floor is open for questions. So let me start. So the objective for today, we're going to define the alternation in the mental status in children using objective scales, discuss the differential diagnosis of altered mental status in children, describe various etiologies of altered level of consciousness and their diagnosis and management. And at the end, we're going to have a summary or summarized approach to such patient. It's going to be mainly case-based, so a couple of real cases. So hopefully it's going to be enjoyable. So let's start with the altered mental status in children. So the problem when it comes to kids is sometimes you don't know exactly, are they really altered? They have a problem with their conscious level, or they're just a kid? He's just playing with you. He's not in his normal mood that day. Or maybe he's tired it's because it's like 2 a.m. in the morning, and for some reason the family brought him to the ER. So sometimes you don't have a good handle on the patient. You're not sure if really that's him or that's not him, that's normal or abnormal. So you have to be careful. You have to compare his presentation to his normal state. So you have to ask the parents about how was he doing earlier that day, what typical he looks like, those kind of questions that might help you. And also look for age-specific behavior. So it's not a single symptom for single age. For example, irritability, and I'm going to talk about that several times. Irritability can be a sign of encephalopathy in younger children, so which is not typical for adults, for example. Irritability is not a typical sign of or symptoms of decreased level of consciousness in adult. Anger, moody, so it can be just being angry and being moody. It could be a sign of decreased level of consciousness. Definitely sleepiness, personal changes or personality changes or behavioral changes. These can be a sign of abnormal altered level of consciousness. And decreased interaction. So the child is not as active as before, he doesn't smile as frequent as before. These are things or clues in the history and exam might help you to say, okay, this patient definitely has something and they need to investigate, or maybe it's nothing, just reassure and send him home. When it comes to definition, so if you look at the bottom of the screen, so we have the Glascom Scale. You guys all know the Glascom Scale. We're gonna have it in a second, the next slide, but normally it's 15 out of 15. If you have something between 3 to 15, that's altered mental status. Less than 3 is comatose, coma or patient is comatose. Now, before we talk even in details about the numbers and the definitions, what's consciousness? So it's really the quality or the state of being aware, especially of something within oneself or surrounding. So that's the definition of them being conscious and aware about what's going on around me. Altered level of consciousness is not a disease itself by itself. It's just a symptom or a sign of something, and you have to look for other causes once you see that. So it's not, you cannot tell me the doctor, I have a patient who with the decrease of level of consciousness, I'm gonna admit him. So you have to tell me why you think he has decreased level of consciousness. Now, going back to the Glascom Scale, so normal is normal, so we're not going to talk about normal. But when it comes to altered mental status, we have different definition or different stages. A patient might be just lethargic, so that's a depressed conscious level resembling deep sleep, but patient can be easily aroused and quickly returns to a previous state. So that's lethargic, so he's there. He looks like he's someone who's sleepy, but once you stimulate him, it's easily arousable. Now, stuporous and obtunded, you might have two definitions for each one or different definition for each one, but generally speaking, patient is not totally asleep, but demonstrates diminished responses to external stimuli. So he might not respond completely to you from the first stimuli or a simple stimuli. You have to stimulate him more and more. You might need to produce a painful stimuli to arouse him. So this kind of how do you differentiate between just a simple lethargic patient to a stuporous or obtunded patient? It's really the amount of stimuli you have to apply with the degree of the stimuli you have to apply to get them awake or back to their normal conscious level. Coma is complete unawareness of surrounding. So patient is unconscious and he's not aware of what's going on around him. He's completely comatose, and that's when the Glascom is less than 3. That's your emergency. You have to maybe admit the patient to the ICU and so on. These are the pediatric Glascom scale. So it's similar to adult. It's not that different from the adult one. Thing I would like to bring your attention to is 0 to 3. So like the first 2 years of life, things might be a bit difficult to do the Glascom scale. So look for other like smiles, coos, cries, these in terms of for the verbal, because the patient is not going to be or not expected to talk. So if he smiles, cooing, crying, probably that's normal verbal. He cry, how loud is it? Is it normal or not normal? The kind of abnormal crying or screaming, that could be a sign of difficult verbal when it comes to verbal. Grunting or complete no response. So this is just something to focus on in younger patients or younger children. Your typical verbal assessment is different than assessing an adult, older children and adult. Okay, so what you need to do in initial approach, as you all know in the ER, you have to do your ABC. So airway, to make sure the airway is patent, oxygen, apply the oxygen, check the oxygen level, IV access, perfusion, these kind of like emergency measures. So you have to do that regardless before even moving to the next step. Vitals are very important, so you have to keep that in your mind, because as a neurologist, one of the things that you have should cross your mind is increase ICB. So you have to keep that in your mind. And as you all know, ICB is not a single abnormal vitals. Actually, they change with time. So the patient might have bradycardia early on, then might go to that tachycardia, hypertension, Cushing triad, widened pulse pressure, and eventually late finding will have the Cushing triad. So the patient might have only bradycardia in the beginning, then hypertension might come later on. So the patient needs a sequential monitoring of his vitals to assess, especially if you think about the possibility of ICB. Labs, that general, you have to tell your labs according to the patient, but generally speaking, you have to do glucose. So that's the first thing as a pediatric. I mean, hypoglycemia is one of the main causes of decreased level of consciousness. Electrolytes, including renal function, urea, uremic encephalopathy is one thing. Blood gas, definitely acidosis can give you a decreased level of consciousness. CBC due to severe infection, for example, or anemia, might cause blood culture if we think about infection. Liver, including ammonia, hyperammonemic encephalopathy is common. Drug screen if the patient is or the history is suggestive of toxicology, and EKG if there's a history of cardiac disease or a possibility of cardiac disease. So these are just general labs. Neuroimaging, so definitely have to think about that. Generally speaking, all children with acute coma of unknown etiology should undergo imaging, head CT scan. So that's a general rule. If you have a children or a child with unknown, unexplained coma, you're almost obligated to do a CT scan head just to make sure you're not missing anything. But also you have to obtain or think about obtaining CT in this following situation. If there is a signs of increased ICB, definitely you have to get a CT. If there is a trauma, I mean, it goes without saying, you have to do a CT scan. Focal finding on exam, you have to image the patient. Deficit in like weakness on one side, you have to examine, you have to image the patient, either CT at least or MRI if you can. Suspected shunt malfunction, patient with hydrocephalus already having a shunt, and he presented with vomiting, fever, increased white head circumference if he's still young. These are the signs of shunt malfunction. You have to do a CT scan or at least image the head. And if there is a coma patient or a decreased level of consciousness in a patient who's unsupervised, then you're not sure exactly what's going on. You have to cover all the bases by getting a CT head, make sure there is no tumor, there's nothing bleed or something that you're not aware of, giving the lacking the full history of an unsupervised child. Now, this is one study when they looked more than 330 or something patients, pediatric, presenting to the ER with altered level of consciousness, and they looked at the different differential diagnosis, different differential diagnoses could explain their decreased level of consciousness. You can see the bars. So we have the dark or black. Then you have the gray and the light gray. That's actually the ages. So you can see on the right side of the screen, the black is 1 to 5, the gray is 6 to 12 years, and the light gray is 13 to 17. And you can see neurology or neurological causes, actually, they do account for most or at least good number of causes of altered level of consciousness in those patients. And it's quite equal among different ages. So neuro is always there. And as a neurology resident or neurology doctor, I mean, most likely you'll get called about those patients because neuro is one of the common things that can cause, neuro causes can affect the level of consciousness. Definitely you have to think about other causes. Toxicology, for example, so toxins. more common in older children rather than pediatric, but again, drug ingestion by mistake is always there. Infection, it's more common in younger patient, but again, you can see it in older patient. Trauma, psychiatric, endocrine, structural, metabolic, others. So you can have an idea about how common. Always think about neuro, infection, toxicology, and trauma, generally speaking, among different age groups, before you move to a different etiologies. So that's when it comes to differential diagnosis. We're going to talk about that in more details. Okay, let's start with case 1. I'm trying to keep my eye on the time. So Layan is a 4-year-old girl, known case of idiopathic thrombocytopenia and recurrent orbital cellulitis, present via AMS with decreased level of consciousness and drowsiness for 24 hours. So this is a known case. She does come with this presentation quite frequently, but this time she was more drowsier than her usual. She comes to the clinic, to the ER, every 2 weeks or so with her recurrent orbital cellulitis, but this time she's even more sleepy. And her mother she's very good when it comes to like taking care of her daughter. But this time she was really frightened, and she brought her to the ER. Because Layan is different. This is not her typical ER visit. So they did the glucose was 94. She was well, or at least at her usual state of health up until yesterday. No recurrent illness or recent illness or fever. Initial vitals were normal. Patient was a bit somnolent. She was vomiting. She was pale, ill-appearing, intermittent eye division and posturing. She does develop the bradycardia, hypoxia, and unequal pupils later on that day. So now you know there is something wrong with this patient. This is not her typical presentation due to orbital cellulitis. CT scan was done, and unfortunately she has an intracerebral bleed. So this patient had thrombocytopenia. Her platelet at the time was I think it was 17,000 if I'm not mistaken. So it was less than 20,000, your key number for possibility of spontaneous intracerebral bleed. And as you can see, she has that bad intracerebral bleed. I'm not going to discuss this case in details, but that brings you to the first differential diagnosis, is vascular diseases. So you always keep in your mind, yes, it's not common in pediatric, but it can happen. It's more common in our colleagues and adult. But generally speaking, you have to keep that in your mind. So subarachnoid hemorrhage can be sudden, severe headache, with or without neoplasm, infection, leukemia, hemophilia, or thrombocytopenia like our patient, sickle cell, abnormal ingestion of drugs that can cause bleeding, congenital heart disease. So something to keep in your mind. Other common presentation in pediatrics, especially neonate or a bit older infants, vascular malformation or aneurysm. So ruptured aneurysm is the most common cause of spontaneous bleed in pediatrics, so keep that in your mind. It can be arterial, can be parenchymal. We're not going to go in details, but something to keep in your mind. To continue on the vascular segment, so cerebral infarction is not common in pediatric, but it actually do see that in every couple of months or so. Sickle cell, for example, they have the increased risk, transient cerebral arteriopathy, other causes of infarction. So it's something to keep in your mind. It can be thrombotic, hemorrhagic, or embolic. As we said, like sickle cell is quite common. 7% of all sickle cell patients might have stroke at some point in their life, and you have to treat with exchange transfusion. Congenital heart disease is second most common cause of stroke or embolic stroke in children. Central venous thrombosis is quite common, especially with infections, otitis media, or mastoiditis, and it can go without good diagnosis, so it's commonly underdiagnosed. Keep that in your mind. It can be due to, as we said, infection or due to hypercoagulable state. So patient with neoplasm, fever, severe dehydration, infection, even systemic infection can cause cortical sinus venous thrombosis, and most commonly due to otitis media or complicated otitis media. So something to keep in your mind. You have to have a vascular image, so CTV or MRV to better diagnose such patients. You have to have your colleague in radiology to pick up, because sometimes can be subtle in MRI or imaging. So you have to keep that in your mind when you approach such patient. Okay, moving on to the second case. The second case is, let's go back. So this is a 2-year-old female present to the ED at midnight with her mother, who reports that the child is hard to wake up. She is afebrile. She was well prior to being left without mother sister for the evening. On exam, she has normal vital signs. She's asleep, but arousable and responsive to stimuli, but she quickly goes back to sleep. No evidence, sorry, there's a typo, no evidence of external trauma. So that's the story. She was brought at midnight because she was difficult to wake up. She was left with her auntie. There's no evidence of trauma, really nothing. It just, that's not normal for her, according to her mom. And now you are in the ER, you have to deal with this. As usual, you did your workup. Glucose was 87. CBC's complete metabolic panel, urine analysis, all within normal. And reassessment remains sleepy, but well aroused to gentle stimuli. She started to have some chorea-like movement. The question was to do a CT or LP here. Maybe she had an infection. She had a CT scan was normal. And later on, you started to get more information from the history. And actually, she did have drug ingestion. So she was positive for a haliperidol. So that's something to keep in your mind, especially in younger children, is drug ingestion. This is, again, a case, a real case. So the patient might have toxicology due to drug ingestion, less likely due to cocaine and others, but drug ingestion, phenobarb ingestion. I have a couple of cases of halidol. Phenobarb is not uncommon, especially in an epileptic patient. So something to keep in your mind. This patient, I think one of her family members was on halidol for whatever reason, psychiatric problem, and by mistake she took a good amount of halidol. I don't remember exactly how much, but she was definitely toxic according to the lab, and she presented with encephalopathy, and later on she developed the typical extrapyramidal symptoms of haliperidol. So toxicology. So this is just an exogenous substances may cause altered mental status, either directly, so they can affect the brain directly, or by inducing hypoxia, acidosis, enzyme inhibition, hypoglycemia, or even seizure, especially in antipsychotic or anti-epileptic medication. So regardless of the cause, they can cause it directly or they can cause it indirectly through different mechanisms. You have to keep that in your mind. Common drugs, sedative drugs, so keep that in your mind. Antihistamine, which is quite commonly used in pediatrics. Phenobarb or barbiturates, benzodiazepine, ethanol, maybe not in our region, and narcotics. Tricyclic antidepressant, anticonvulsant, salicylic acid. So we had recently a patient presented with aspirin toxicology, or toxins overdose, but he wasn't really, he did not present mainly with altered level of consciousness, but he presented he was normal, but he was found to have high aspirin because they found the bottle beside him, but he remained okay throughout his admission to great extent. So, but again, aspirin is one of the possibilities because it can cause bleed, as you all know. So patient might have decreased level of consciousness due to cerebral bleeding indirectly. What you need to do when you think about drug overdose is ABCs, again, like usual. Examine your patient, look for pupillary sizes. You might have narcotics causing pin pupil, reactivity, again, narcotic sedative might affect pupil reaction. If you think there is a drug ingestion, especially if you are within the first an hour and a half, you might think about activated charcoal to get the drug out as much as you ask the patient or induce the vomiting with the patient. Naloxone, if opiates is a possibility in older children. Clonidine, by the way, clonidine is commonly used in autism patient, hyperactivity patient. Clonidine per se can cause can be overdosed, one, and can cause decreased level of consciousness. And for some reason, naloxone actually might work in clonidine overdose. It does work in the opioid receptor, and clonidine also has some opioid receptor effect. So, people might suggest to use that as a trial for clonidine overdose. If the patient is autistic or has been on clonidine and for some reason received a higher dose of clonidine. Hypoglycemia, so something to look for because commonly seen in drug ingestion, especially with ethanol, oral hypoglycemic, beta blockers, aspirin, and insulin, if the patient for some reason got exogenous insulin. So these are the things that you look for, again, as a quick screen when you think about drug overdose. Case 3. So this is a 5-year-old male present with headache, fever, and sore throat. He stayed in his bed all day that day, which is not typical for him. He did not want to play or watch TV. That's, again, very atypical for a 5-year-old. And his gait was a bit off when you examined him. Other than that, he was just curled in his bed, covering his head with a sheet. So that I'm not saying this is a clear exam, but if he's really keep covering his eyes with a sheet, maybe he has photosensitivity, something to keep in your mind. Because in pediatrics, reobservation is more than 80% of your exam. So you have to be smart in picking these subtle clues. Maybe he's covering his eyes because he doesn't like light, for example. He screams widely when you try to examine him, but he calms quickly. So that tells you there is no major issues, because if he screams, then once you play with him, he calms. I mean, something is reassuring there. Gradually with time, you started to be able to examine him. So he's not really putting a fight, as they say, because he's becoming more used to you, and he's more calm and maybe more lethargic too. So something to keep in your mind. So when you see this, the first thing that should cross your mind is infection. Fever, sore throat, headache, photosensitivity. Maybe this patient have meningoencephalitis. So something to keep definitely in your mind is, could this be meningoencephalitis? Now, the problem is most of the time those patients, not most of the time, but a good number of the times, this patient might misdiagnose as meningoencephalitis and he has something else. So what I'm trying to say is, like, don't ascribe everything to the viral illness, or say, okay, he's just weak because he has a viral illness, or he doesn't have meningoencephalitis because he has just a sore throat that's most likely viral, and just send him home without anything. So one, it could be not an infection, so it could be ADEM, for example, acutely disseminated, or some, especially our doctors, might just say, okay, he's a bit weak, he's lethargic, he's not active because he has sore throat, he has sinusitis. Just treat with good hydration, reassurance, and send him home, and they will come to you again in a day or two with severe meningoencephalitis. So I'm not suggesting to LP every single patient comes to the ER, but if there's enough clues in the exam and history to think about meningoencephalitis, you have to do your workup to rule out meningoencephalitis. Now, infection is not uncommon, as you all know. It's actually it's the most common cause of decreased level of consciousness in middle or school-age children. Viruses, I mean, as you all know, these are all the viruses can cause meningoencephalitis. Then you have bacteria, you have spirochete, you have fungi, you have parasite. So it really depends on the region, the family history, the history itself. That will give you a clue. Most likely you will have your help. You have the help from the ID and the pediatric team when it comes to that. But the thing that I would like to mention here before I leave is signs of meningitis. So in younger patients, less than 2, you might not see your typical knuckle rigidity, Kernicks, and Prudzinski sign due to incomplete myelination. So don't look for these knuckle rigidity, Kernicks, or Prudzinski signs in younger than 18 months or 2 years, because you might not see it. It has to do something with, first of all, anterior frontal being closed and complete myelination. So if you don't have, or you have either of those, these two are not fully finished yet or not completed yet, the patient might not develop the typical signs of meningoencephalitis. So look for other signs of meningitis, maybe bulging fontanelle is open, level of consciousness, fever, irritability, those kind of things that we talked about before. Now, just a clinical pairs, if they have a younger child who does not calm when you put him on his mother's hand, that should be a red flag. Maybe this patient is like, there's something wrong with the child. So if he gets fussier every single time his mother carries him, that's not typical for children. Again, I'm not saying every single child who cries on his mom's has to do an LP, but again, I'm trying to widen your eyes. If you can just get some of the clinical pairs when you see a patient in the ER and you don't have time, or the patient is not cooperative, he cries all the time, try to pick the hints from here and there to defend your suspicion and impression, and again, to guide your investigation and management. So that's what we talked about. Now, infection. So one of the common thing in pediatric is SSV infection or herpes encephalitis. It can be bad. So death or mortality can be up to 70%. So be careful. They have a predilection for temporal lobe. Nobody knows exactly why, but most likely due to direct invasion from the nose. So it's really started the nose infection followed by direct invasion to the temporal lobe, being the closest loop to the nose. It can present with seizure, edema, and ankle herniation. You can see the EEG. There is what we used to call it periodic lateralized epileptiform discharges. So something to look for. EEG might help you to diagnose. MRI definitely will be very helpful in those patients, especially it should be done with contrast if possible. Other viruses, varicella, So keep in your mind, especially if there is a clear rash initially, then within a week or so, the patient develop this decreased level of consciousness. Mumps, measles, other viruses definitely should be in your differential. Nowadays, it's really winter is coming, or maybe I should say fall. I don't know if we have fall in Saudi Arabia, but with this season, respiratory infection started to get more and more. So you might get to see more viral illnesses causing simple infection all the way to severe meningoencephalitis over the next 3 months or so. Other infection, before we leave the infection part, is focal infections. So plain abscesses due to whatever reason, chronic sinusitis, chronic otitis media, dental issues, so the endocarditis sending the infective emboli to the brain. So these are the things. Subdural empyema, especially secondary to severe bacterial meningitis. Epidural abscess is very rare, but something to keep. You might need to have a surgical drainage for those patients. Now we're talking about flu vaccine. So just one slide about influenza. So it's really an overlooked cause of the decreased level of consciousness of or mental status in children. They might present with broad array of manifestation, those patients with influenza. So altered mental status, seizure, cranial nerve abnormalities, hallucination, abnormal behaviors, and persistent irritability. But don't forget, those patients, they don't have typical meningoencephalitis. They have this abnormal presentation due to hypercytokinic or hypercytokines state, not a primary CNS infection. So patient with influenza might have some neurological symptoms, but typically it's not due to direct infection of the brain or meningoencephalitis. It's just part of their severe viral prodrome due to influenza. And that you might actually get to see over the next couple of months due to influenza season. Okay, we're moving on. Case 4. This is an 8-year-old boy presented to the clinic with 14-day history of sleepiness and abnormal or recurrent falls, abnormal gait. Had a history of respiratory infection 2 weeks prior to the onset of the symptoms. Here, I mean, it's not your typical infection. The patient is not febrile in front of you. He had a history of fever 2 weeks ago, but now he presented with increased sleepiness or encephalopathy and abnormal gait. Here you have to think about post-infectious process, and one of the common thing in pediatric is ADEM. So acute disseminated encephalomyelitis is one of the things. So this is the MRI typical for ADEM. Here it's good to do a contrast. You might see some contrast enhancement. ADEM is a gray and white matter disease. So you might see both gray and white matter involvement in the MRI. For the sake of time, I'm not going to talk about ADEM in details, but it's not uncommon, and we see it maybe every couple of months. We see a case in the hospital. It can present with motor and sensory ataxia, weakness, decreased level of consciousness. By the way, encephalopathy is the cardinal feature of ADEM plus something else. So that's what I was talking about, motor or sensory or ataxia. But you have to have encephalopathy until now as part of the clinical diagnostic criteria for ADEM. Treatment, as you all know, is steroid. If not, you can try IVIG, maybe plasma exchange. This is the MRI diagnostic criteria. Sorry, this is the clinical diagnostic criteria for ADEM. I will just skip it for the sake of time, but there is a diagnostic criteria for ADEM. There is an MRI diagnostic criteria. There is a recurrence ADEM or multiphasic ADEM. So a couple of things about ADEM can be. And before we leave ADEM, other autoimmune encephalitis should be in your differential, especially anti-NMDA, being the most common antibody-mediated encephalitis in children. Case 5. So this is a real case just discharged, I think, yesterday or the day before yesterday. There's a 2-month-old or almost 2-month-old male present with 5-day history or more of decreased level of consciousness and abnormal movement, consists of what looks like a myoclonic jerks. It's not typical for infantile spasm, but it's there, and it's actually multifocal myoclonic jerks. Perinatal history was unremarkable. Family history, he had an older brother with epilepsy. He died at age of 4, I think. On exam, it's only hypotonic, no clear dysmorphic features. You did your EEG, and there is clearly there is an abnormalities in the EEG. This is your typical burst suppression pattern in EEG. So this patient, you have to think about Ohtahara versus early epileptic myoclonic encephalopathy. This patient had an MRI, was a reassurance, and we're waiting for the genetic test to come back. He was started on vitamin B6. He showed some response initially. We'll see. We just started that 2 days ago. So maybe it's a vitamin B6 dependent epilepsy, maybe not, but definitely metabolic causes or seizure or status epilepticus should be in your mind, and that will take us to seizure. So seizure is definitely, as a neurologist, one of the common things you have to think about. It can present with decreased or diminished level of consciousness. either during the seizure, so due to as a convulsive status epilepticus, or after the seizure activity, as you all know, what's known as post-ictal drowsiness or post-ictal decreased level of consciousness. Starting with the post-ictal, so the patient can be confused, lethargic, fatigued, irritable. All of these can be a sign of post-ictal. Usually, he will gradually return back to normal. It depends on how long was the actual seizure, so it's really proportional to the length of the seizure. The longer the patient was seizing, the longer the post-ictal, plus or minus. Again, partial or absent seizure more stable and more subtle, and usually they don't present with typical altered level of consciousness. We're talking about more of a convulsive generalized tonic-clonic seizure. And on the other hand, status epileptic. So patient with status epilepticus definitely might have decreased level of consciousness. They might have convulsive status in the ICU, or maybe non-convulsive or subclinical. So here you have to have your EEG to help you. And this is not uncommonly encountered in the ICU setting. Patient is tachycardic or autonomic dysfunction unexplained by medical problems. So you have to think about the possibility of non-convulsive status. You have to get your EEG and hopefully use your EEG to guide your treatment or to escalate or de-escalate.
You have more slide or?
Okay, we're almost there. We have 3 more slides or 4.
Okay.
Now with the seizure, so it really depends on, this is just how to think about it. Again, when it comes to seizure, you have to take good history, pre-ictal, post-ictal, or ictal, fever versus not, maybe infectious, maybe autoimmune. So again, medication, maybe medication inhibition was like he was not taking his medicine or overdose. This kind of thing that you might help you to reach to the diagnosis. Structural, so for the sake of time, this is a case last week, known case of hydrocephalus, presented decreased level of consciousness, no fever, found to have a shunt malfunction, underwent shunt revision, and she's old. This was 2 weeks ago. I just saw her yesterday, and she was fine, at least back to her usual state of health. So keep that. Structural possibilities, structural problems is a possibility, either mass lesion, hydrocephalus, or shunt malfunction. Look for signs of increased ICB as a possibility. Neoplasm is not common, but it can be. Look for other symptoms in neoplasm, like decreased level of consciousness with ataxia, maybe brain stem versus cerebellar, like medulloblastoma, decreased level of consciousness with seizure. Look for cortical tumors. This kind of thing might help you to at least clinically. Then you will get to do your MRI to diagnose. This is, I think, the last case. So a 6-month-old present with to the ED with parents who report that he is hard to wake up again. There was really nothing on the exam. It just he's like less active than expected. What I'm trying to put here is like bleeding, and at the same time to talk about child abuse. So child abuse is not uncommon, and you have to keep that in your mind. One of the features for child abuse, you just might present with decreased level of consciousness. You have to have high index of suspicion. You might need to do an image to rule that. You have to examine to look for other signs of child abuse, and you have to do image to make sure there's no bleed. And then you have either subdural, epidural hematoma, and you guys know the differences between subdural and epidural. We're not done with the differential diagnosis. Metabolic definitely can affect your level of consciousness. So you have in the slide all the metabolic. Don't forget glucose, electrolytes, uremia, and amonemia. So these are the common things, but other possibilities always there. This is just a slide to use as an approach when it comes to altered level of consciousness. And to summarize, the altered level or altered mental status, keep your differential diagnosis open and wide. Pursue multiple possibilities until you are able to discard them. So you might need to just throw your investigations, especially in the acute setting. Then you can discard or delete one of these differential based on the result of the investigation. Be ready to change your mind completely, and it happened several times before. I think a seizure, then there is a clear bleed in the brain. I think it's just a simple headache, then there's a bad tumor in the brain imaging. So be ready to change your mind based on the result of the investigation, and make sure your altered child gets his vitamins. Vitamins, I mean vascular, infection, toxin, accident, abuse, metabolic, even inception in younger children, neoplasm, and stroke differential. So make sure you have you have gone through all of these differential diagnoses before you send your patient home. You don't want to miss a child with a brain bleed who comes next day to you with the seizure or almost comatose. And I think that's it. Thank you.
Thank you very much for your contribution. And to you, Dr. Afnan.
Thank you, Dr. Ahmed, and all speaker. I think now the floor is open for any question or comment. I have one question here. What's the most age we can diagnose epilepsy? I think Dr. Rashada can answer this question if she's with us.
Yes, as I mentioned, the age of epilepsy can be as early as the neonatal period.
Okay, thank you, Dr. Rashada. And another question. In a neonatal seizure, when we have to consider stop medication?
So the new guidelines, no, not guidelines, the new study recommended to discontinue the anti-convulsive medication as early as possible. But the exact date, it varies between the study. Some they immediately after 72 hours from the acute symptomatic seizure, they will stop. Some they will stop it before discharging the patient.
So there is no clear guideline for this.
No, the recommendation is not to keep them on a prolonged maintenance period as with other age group like 6 weeks or so, or three months after acute symptomatic seizure.
Okay, thank you, Dr. Rashada. So thank you to all. I think we have 1 hour break, then we'll resume our activity at 1 p.m. Thank you.
السلام عليكم دكتورة.
أهلا وعليكم السلام.
أهلا يا دكتورة، حياك الله.
أهلا الله يحييك.
باقي دقيقة إن شاء الله ونبدأ، دقيقتين ونبدأ إن شاء الله. دكتورة أفنان نبدأ؟
أيوة دكتورة دينا.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. We will continue the second session of Fundamental of Pediatric Neurology. Today in the afternoon, we will talk about febrile convulsion. How much do you know? By Dr. Ayat Safar. Dr. Ayat Safar finished her Saudi board in general pediatric 2012. Then she pursued her fellowship in pediatric neurology at Sydney Children's Hospital, Australia. Currently, she is working as a consultant pediatrician and pediatric neurologist at King Fahd University Hospital, Al Khobar. And as we mentioned before, she will talk today about febrile convulsion, how much you know about it. So welcome, Dr. Ayat Safar.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear my voice very well, and can you see the slides?
Yes.
So thank you, Dr. Adina, for introducing me, and thank you for having me in the course. I'm going to talk about febrile convulsions, which is a very common neurological presentation in childhood. As for every 100 kids, there are 3 to 5 will experience 1 or more febrile seizures. But this prevalence is actually variable according to the geographical location, and it can reach up to 14% in some countries and only 1% also in other places. I will start by going through some basic concepts, then session will be more interactive by answering questions about some case scenarios. So please be there and we will wait for your participation. It's good that there are some recommendation guidelines for this topic, which I depend on as reference. As you can see, American Academy of Pediatric Guidelines, International League Against Epilepsy, and the most recent systematic review about complex febrile seizure in 2017. And so starting with the important terms in this topic, febrile seizure means any seizure happening with a fever. And we can call it simple febrile seizure when the following criteria can be applied. If the febrile seizure happened in context of temperature more than 38.5, and the seizure was a generalized convulsion one, and it lasted less than 15 minutes with complete recovery within 1 hour, and it happened as a single seizure within 24 hours of the illness. In contrast, complex febrile seizure, when the criteria is not fitting the simple febrile seizure, if it happened in context of low temperature, if it was focal seizure, either with ictal features, which are focal, or post-ictal focal deficit. If it is prolonged, lasted 15 to 30 minutes, or it happened as multiple within 24 hours. Febrile status epilepticus, if it is lasted more than 30 minutes. The most common of those is the simple febrile seizure, which accounts to 3/4 of the febrile seizures. And next is complex febrile seizure. Focality, either ictally or post-ictally, accounts for 4 to 16% of the febrile seizures. Actually, simple febrile seizures is not as simple as that. This criteria can be applied for many patients, yet still to call it simple, we need to confirm that it occurred at the usual age range between 6 months to 60 months, which equals 5 years. Some believe that it can occur at any age between 1 month until 6 years. Yet if it is at the extremes of this age range, diagnosis has to be by exclusion. Also, onset of the first episode of simple febrile seizure usually occurs before the age of 3 years, which is almost nearly 90% of the simple febrile seizure. So if it occurred beyond that, it will be questionable. And 98% occur in the first 24 hours of the febrile onset. So when we know this information, again, we have to be cautious to label any patient having simple febrile seizure if it occurred differently from what we know. We also need to confirm that the patient has no signs of CNS infection, no metabolic disturbance causing provoked or symptomatic seizure, and he has normal development, no previous afebrile seizures, and no significant prior neurological abnormality. Those further specifications for simple febrile seizures were added in order not to miss other serious differential diagnoses. And the most important and most common of them is CNS infection, including meningitis and encephalitis. As 15% of children with meningitis will have a seizure as a presentation, and meningitis is reported in up to 18% of children with febrile status epilepticus. Also consider the risk of provoked seizures during the febrile illness, like, for example, provoked by hypoglycemia due to poor feeding while the patient is sick. And other non-epileptic events can happen during a serious or febrile illness, like syncope, shivering, shuddering. Also, dystonia can be worsened by infections. And very important differential is genetic epilepsy, like SCN1-related severe myoclonic epilepsy of infancy, or what we call it, a Dravet syndrome, and generalized epilepsy with febrile seizure plus BCDH19 epilepsy, and mitochondrial disorders where the patient might have other problems and can present with worsening during febrile illnesses or infections. Thus, it's wise to keep a list of red flags in order to catch the non-classical presentation of febrile seizures and to think about other differentials. If the patient is presenting beyond the typical age, either less than 6 months or beyond 5 to 6 years, or the onset of seizure beyond the age of 3 years. So we have to think about other differentials. If the patient had previous afebrile seizures, even if he presented now with simple and typical febrile seizure, progressive neurological condition and prior developmental delay or regression or following regression after this febrile seizure, presence of complex features of the febrile seizure, as we mentioned, seizure at low temperature, multiple seizures, focality, and prolongation, and if the child didn't return to normal mental state within 1 hour. If there are signs or symptoms of CNS infection, and if there's no clear focus of the infection, and if the patient is clinically unwell or hemodynamically unstable. And now let's start with the first case. A 19-month-old boy presented to the emergency department after he had a generalized onset convulsion of all limbs, lasted 3 minutes at home, and aborted. He regained his full level of consciousness soon after arrival to the emergency department. That was in context of acute tonsillitis found on examination, and his temperature was 39.8, which is the best next step from the following. Will you do basic lab tests, glucose, CBC, electrolytes, calcium, magnesium, phosphorus only? Will you do lab tests, lumbar puncture, admit to hospital and arrange for EEG and neuroimaging? Or you will do lab test urgent, CT brain in the emergency, followed by lumbar puncture, or you will not do any labs or lumbar puncture? Can we share the choices? We will be waiting for your participation in answering the question within the next 15 seconds. Okay, so most of you choose to do everything, to do lab test, lumbar puncture, and admit to the hospital. Actually, my answer is not to go for any labs or lumbar puncture. So this patient is having simple febrile seizure by all the criteria that we have, and he has acute focus, and he regained his normal consciousness, and examination, like we didn't mention in the scenario, but examination is normal. So the recommendations for simple febrile seizure is that labs are should not be performed routinely unless if we are suspecting another associated problem, and lumbar puncture is not indicated in this context, and we'll come back to the lumbar puncture. And the guidelines are against routine neuroimaging, and EEG should not be performed in neurologically healthy patient with simple febrile seizure. So if it is straightforward, only simple febrile seizure, and there's focus of infection, patient is otherwise well, and we don't have any of the red flags. So these are the recommendations. And regarding the admission, particularly, the guidelines from the International League Against Epilepsy, that the admission can be considered if the patient is less than 18 months of age, for observation for possible evolution of the clinical presentation, and he might need lumbar puncture. Otherwise, if the simple febrile seizure occurred more than 18 months of age, admission is not necessary. And if the patient is already diagnosed with simple febrile seizure and it recurred again, admission is not necessary for the other one. Okay, case number 2, a 14-month-old boy presented to the emergency department, again with generalized convulsion of all limbs, lasted 3 minutes at home and resolved. That was in context of temperature of 39.8, but this patient had an oral antibiotic started 1 day prior to the presentation. What is the best next step? Will you do basic labs, lumbar puncture, lab test and lumbar puncture, or no labs or lumbar puncture are required? What do you think? Okay, so most will go with the lab test and lumbar puncture. Thank you. So that's what I will do. And actually, lumbar puncture is indicated in specific situations if the patient is presenting with the typical simple febrile seizure with all criteria applied. So it is indicated when there are meningeal signs and symptoms at any age. If an immunized, if unimmunized patient aged 6 to 18 months of age, especially those deficient with the Haemophilus influenza vaccine or strep pneumonia vaccine, or when the immunization status cannot be determined. And for those patients, there's an option for observation for 24 hours, then decision about what to do. For those patients who are less than 12 months of age, most of them will not exhibit clear symptoms and signs of meningitis, so we have to be careful with them. And also lumbar puncture is an option for children pre-treated with antibiotics, as we have in this case scenario. Okay, case number 3, an 18-month-old boy presented to the emergency department again with generalized convulsion for all limbs, lasted 3 minutes with temperature of 39.8. Examination confirmed the presence of acute tonsillitis. What is the best management from the following? Start oral antibiotic or prescribe antibiotics and advice for early use of antibiotics for the next febrile illnesses. Provide rectal diazepam for PRN use when the patient develop another febrile seizure, or start a prophylactic anti-seizure medication like valproic acid. So most of you voted for prescribe antibiotics and advice for early use of antibiotics. For me, I choose start oral antibiotic. And that's based on the recommendations that the most simple febrile seizure spontaneously cease within 2 to 3 minutes. So we don't need prophylaxis as anti-seizure. If longer, apply acute management of seizure. Prophylactic anti-seizure medications are generally not recommended, and there is convincing evidence that antibiotics are not effective in preventing febrile seizure recurrence. So it's not a management that will reassure the parents that the patient will not develop seizures. And parental counseling in this is very critical. And when they understand, I think these points, it will be reassuring to them. Okay, case number 4, a 2-year-old girl presented to the emergency department after she had a generalized convulsion of all limbs at home while febrile with temperature of 39.8. It lasted for 10 minutes and she regained consciousness gradually over the next 90 minutes. 2 hours later in the emergency department, she had another generalized convulsion stopped by IV diazepam given at 5 minutes of her seizure. Exam findings of reduced level of consciousness and left-sided hyperreflexia and positive clonus. What is the best next step from the following? Do basic labs, lab test and lumbar puncture, labs, lumbar puncture and EEG, or labs, lumbar puncture, neuroimaging and EEG? Okay, yes, I totally agree with the most of you to go for the lab test, lumbar puncture, neuroimaging, and EEG for this patient. So that's a complex febrile seizure because of the recurrence. Patient also didn't regain a level of consciousness. We don't know whether it's medication related or not, if the exam was done early after giving diazepam or post-ictally, but still, like, we don't know when the patient will regain her consciousness. So the recommendations for complex febrile seizures are not very clear. Lab tests are possibly to be done by International League Against Epilepsy. Lumbar puncture, there is no clear evidence. It's very similar to simple febrile seizure. If there are suspicious signs or symptoms of CNS infection, if the patient was pre-treated by antibiotics, if he is from an area without access to adequate immunization, or at the outside if the patient is outside the age range of typical febrile seizure also. Also, neuroimaging can be considered acutely if clinically indicated with suspicion of structural lesion or active CNS process. EEG, also there is no consistent evidence for routine EEG to predict subsequent epilepsy or febrile seizure recurrence, either complex febrile seizure or even febrile status epilepticus. But the concept here, which I want to clarify, is that complex febrile seizure, in fact, may result from an acute disorder of the CNS or it can be the onset of a specific epilepsy syndromes, or simply it's a prolonged febrile seizure with the same prognosis of simple febrile seizure. So we don't know which one of those, and therefore approach and management depend upon the etiology of the patient. So it's better to assess the patient further according to his presentation and collect more information from the workup that we are going to do, then to decide where to go. So case number 5, a 5-year-old boy presented to the emergency department after he had a focal onset clonic seizure of his left arm, lasted 3 minutes at home. That was in context of temperature of 39.2. Neurological examination is otherwise unremarkable. Choose the best answer from the following. So this question is to elaborate more about the indications of neuroimaging. So what are you going to choose for this patient? Urgent CT brain, admission to hospital and arrange for MRI brain as soon as possible, non-urgent MRI brain, or no neuroimaging is required. Okay, so most of you choose admission to hospital and arrange for MRI brain as soon as possible, and 16% choose non-urgent MRI brain. So it's non-urgent MRI brain. Since this patient is well, he had a febrile seizure, which was focal, but the neurological examination was unremarkable. So the recommendation is to go for non-urgent outpatient MRI brain for focal complex febrile seizure, and whether the focality is ictal or post-ictal, to look for the underlying structural abnormality or even resultant hippocampal atrophy because of prolonged seizure, and we will come to this later. There is no evidence to use routine neuroimaging for complex febrile seizure without interictal or post-ictal focality, and we have to be careful about this. It's not indicated to go definitely for neuroimaging, for example, for complex febrile seizure happened at low temperature. Urgent brain MRI in emergency department is not recommended, and there's no indication for head CT except if there is concern about acute cranial process. Okay, case number 6, the same patient, and will you go for EEG or not? Urgent EEG, admission and arrange for EEG within 1 week, and outpatient EEG within 1 month, or EEG is not indicated. Sorry, I think we have only 10 minutes left for the presentation. So can we make the time shorter for choices, like 10 seconds only? Okay, so most of you chose outpatient EEG within 1 month. And actually, it's to arrange for it early within 1 week. So EEG for complex febrile seizure is not indicated urgently unless if we are, if the patient is unwell and we are thinking about subclinical seizures. EEG should be considered actually in complex febrile seizures, but the timing is controversial. If doubtful event, whether it is seizure or not, it's better to go for early EEG within the first day or shortly after the event, because it will be of higher yield to show up the epileptic discharges, or if the event will recur during the EEG. Otherwise, the evidence is conflicting, and the suggestion is to do EEG within 7 days to increase the likelihood to find abnormalities. It's not the indication, the absolute indication for admission, but I think for most of our hospitals and centers, performing outpatient EEG within 7 days would be a bit difficult. So maybe admission is an option to make it earlier. And for considering future epilepsies, there is no clear evidence that specific EEG findings are related, but the persistence of EEG abnormalities has more predictive value. And regarding the indication for admission of complex febrile seizure, there is no literature. It is actually recommended by International League Against Epilepsy. But there are factors to consider. As I said, the access to medical services like neuroimaging and EEG, and also if there are social factors, institutional preferences, or regarding the patient himself, if he had multiple seizures or he's having risk of further seizures, if he had a prolonged post-ictal period which requires observation, and there's severity of focality for him. Knowing all these informations and guidelines make I think the pediatrician satisfied to go and manage the febrile seizures, whether simple or complex febrile seizures. And the question is when to do neurology consultation. Still, if the pediatrician is not satisfied, actually, he can do the neurology consultation. And also it should be considered if there is persistent post-ictal deficit or abnormal neurological findings, if there's history of recurrent complex febrile seizures, and if there are paroxysmal events with fever which are unclear to be seizure or not. Okay, case number 7, an 18-month-old boy presented to the emergency department after generalized seizure at home, lasted 3 minutes in context of high-grade temperature, and he had acute tonsillitis. He was treated by antibiotics for this. 4 months later, he presented with the second febrile seizure, similar to the previous one, lasted 2 minutes, and the temperature was 40 degrees. Now, parents are asking you for prescribing a prophylactic medicine for him because he had 2 events. What are you going to do? Start daily phenobarbital, start daily oral diazepam, provide rectal diazepam for PRN use, or provide parental reassurance and counseling? Okay, so most of you answered yes, provide parental reassurance and counseling. And that's based on that most simple febrile seizures are short and harmless. And the routine long-term daily prophylactic anti-seizure medication for preventing recurrence is actually effective by literature, but the risks of side effects overcome its benefits. So that's why it is not recommended. And actually individualized risk-benefit approach is better to be recommended. Since there is efficacy. So some efficacy was reported with phenobarbital and valproic acid as a prophylaxis, and it is generally suggested to start with intermittent rectal or oral diazepam, and then continuous prophylactic phenobarbital or valproic acid can be considered, and it can be considered in specific situations as per the International League Against Epilepsy. If there are frequent seizures in a short period of time, and what we mean by this is 3 or more in 6 months, or 4 or more in 1 year, and that's not applied to our patient because he had 2 seizures only. History of seizure prolonged more than 15 minutes, which means complex or state-specific. Okay, case number 8.
5 minutes.
Okay, thank you. So I think I will answer this to go just quickly. So parents are asking you about the risk of recurrence of his febrile seizures with the subsequent illnesses. So the risk is generally 30 to 50% in children with first febrile seizure, and as general talking, but actually there are risk factors specifically related to the risk of febrile seizure recurrence. If there's family history of febrile seizure in a first degree relative, younger age of onset less than 18 months, low temperature at the time of the seizure, and shorter duration of febrile illness before seizure within 1 hour of onset. And as the number of risk factors increase, the risk of recurrence will increase. So that's individualized risk, and we should answer it specifically for each patient. Okay, and for this patient, an 11-month-old boy presented with the prolonged febrile seizure for 20 minutes, and 4 months later he had another prolonged one for 16 minutes in context of a low temperature the next time. So parents are asking if their child will be going to be an epilepsy patient. And what we mean by epilepsy patient, that he will have afebrile seizures and a risk of unprovoked seizures. What is the risk factor for him that will indicate that he has the risk? So it's actually the number of complex febrile seizures he had. The factors related to this is that, first of all, children with no risk factors have a 2.4% risk of developing epilepsy among the febrile seizures, which is a little bit higher than the risk of epilepsy in the general population, which is 1.4%. The risk factors for developing epilepsy for febrile seizures include family history of epilepsy, neurodevelopmental abnormality, and any feature of complex febrile seizures. And if the number of complex febrile seizure correlated with the higher risk of epilepsy. Okay, the last question here is the parents are wondering if their child will have long-term outcome after his illness when he had febrile status epilepticus. And the risk is to have memory impairment. Febrile status epilepticus accounts for 5% of febrile seizures, and most of them are focal. And there are some specific association that indicates that the patient is at higher risk of febrile status epilepticus. And the prognosis is indicated by the FEBSTAT study, which is a common study that studied the outcome of febrile seizures, where they found that there is a relation with the hippocampal malrotation, which is a common developmental malformation of the brain. And they found that there is acute hippocampal injury, which might evolve into hippocampal sclerosis later on. And those patients might be could be, we are not sure, and there's no clear evidence that they might be at risk of temporal lobe epilepsy later on. The overall cognitive outcome is good, and there is risk of memory impairment for those had developed acute hippocampal injury. What to tell parents? I will not go through this, but just to indicate this literature for you, that there's consistent statement of information to deliver after febrile seizure to the parents, and that's what we mean when we tell the parental reassurance and counseling, to indicate the definition and that these are common harmless febrile seizures, and not all illnesses will develop febrile seizures, and what to do during the febrile seizure, and also how to make the diagnosis, and to reassure them that there is no need for extensive investigations and the prognosis, and that they don't need to use any anti-epileptic medications. So the key messages here that the febrile seizures are common, diagnosis is clinical, most of them are short and don't require investigations. Meningitis has to be considered and LP to be done when it is indicated. Try to treat the cause of the child's fever, and no need for prophylaxis, and prognosis is generally excellent. And if the presentation is not classical, we should take it seriously and investigate for other differential diagnoses. And I suggest the further reading of more concepts about febrile seizures for the genetic epilepsies. If the patient is presenting with a prolonged hemiclonic febrile seizure, think about the Dravet syndrome. If there is recurrent febrile seizures beyond the typical age range, think about generalized epilepsy with febrile seizure plus. If there is early onset to prolonged febrile seizure in female with developmental delay, think about BCDH19 epilepsy. And if the patient is neurodevelopmentally abnormal with disease or regression with high lactate, think about mitochondrial disorders. And there's another concept, if you would like to read about it, febrile seizures, or that's actually it's a seizure in acute infectious illness, like benign convulsion with mild gastroenteritis, which is afebrile. And these are the references, and thank you.
Thank you, Dr. Ayat, for your great talk. Good afternoon, everyone. Today, it's my great pleasure to introduce our next speaker, who's going to talk to us about one of the most important topics in pediatric neurology, which is status epilepticus. Our speaker today is Dr. Dua Baarma. Dr. Baarma is a consultant of pediatric neurology and epilepsy at King Abdullah Specialist Children's Hospital at National Guard Hospital. She's also the director of the Pediatric Neurology Residency Program in the same institute since 2018. She's an assistant professor at King Saud bin Abdulaziz University for Health Science. Dr. Ba'arma completed Pediatric Neurology Residency Program at King Abdulaziz Medical City for National Guard. She joined Hospital for Sick Kids in Toronto, Canada as a fellow in pediatric epilepsy with extra training in VNS and MEC. Dr. Ba'arma is active in the pediatric neurology researches. She had many publications in epilepsy and status epilepticus. Dr. Dua, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Thank you for the organizing committee for inviting me to give this talk. So my talk will be about status epilepticus. So we'll start with the objectives. The objectives is to understand the principle of acute management of prolonged generalized convulsive seizures and to explain the pathophysiology of status epilepticus causes and treatment. So I will start this way in a different way. We'll start with the management and then we'll go to the details. So I will start with a case. We have Khalid, who is a 10-year-old boy who presented to emergency department actively seizing. So always the question will be what we have to do in the beginning. So everyone should know that as a witness for outside hospital, the witness should cushion the head, loosen any tight clothes, turn the patient onto one side, start to count or time the seizure. Don't put anything in the mouth, and we should reinforce this one as in our society, and probably everyone likes to put something in the mouth. So we should make sure that you don't need to put anything in the mouth. Look for any ID. Please don't hold the patient down. And then at the end of the seizure, offer help. And you can call for ambulance if the seizure has a long or more than 5 minutes. So, so upon arrival to emergency department, what is the next step? So upon arrival, what we need always to advise and we have to make sure is ABC as always. So we need to stabilize the patient, airway, breathing, circulation, and disability with neurological exam to make sure if there is any disability there. We have to time the seizure from its onset while monitoring the vital signs. We need to assess the oxygenation, give oxygen if needed, and we can also provide ECG monitoring. We have to collect glucocheck or finger stick for blood glucose. If blood glucose was low, we have to give a treatment with D25 water or D12.5 water. Trying to put an IV access and collect electrolytes, hematology, toxicology screening if appropriate, and if the patient is on anti-seizure medication, also to ask for medication level. So what if the seizure continued? Now we have reached the 5 minutes. Khalid is still seizing. So what will be the next step? So next step from 5 to 20 minutes is to start benzodiazepine. The two important points in benzodiazepine: avoid too many benzodiazepine and avoid underdosing. So most studies found that probably that patients are being underdosed with benzodiazepine. That will lead to failure to abort the seizure. Unfortunately, sometimes doctors don't follow guidelines and give too many benzodiazepine that would lead to respiratory failure. So memorizing the dosing is very important. And it was found that most benzodiazepine, midazolam versus lorazepam versus diazepam are equally effective. Usually midaz we give only one dose. However, lorazepam and diazepam we can give repeat the dose twice. If none of these are available, phenobarbital can be tried, rectal diazepam or intranasal midazolam. It's very important, as I mentioned, that we know the dosing in pediatric and in diazepam. Usually we have a PR dosing. However, lorazepam, midazolam, it's been given mainly IV, and you have to avoid to remember always what's the maximum dose and to avoid it. Remember also that all of them, their side effect is respiratory depression and sometimes hypertension with bradycardia. Here we're comparing benzos with each other, and you can find that they have the onset of action usually is fast in diazepam, midazolam, and longer in lorazepam. However, diazepam can stay in the body for around 60 hours with its half-life. Midazolam and lorazepam, especially midazolam, has really short half-life. Lorazepam has 9 to 21 hours half-life. All are metabolites in the liver and excreted in the kidney. So patient with renal impairment, sometimes with hepatic impairment, sometimes it takes longer sedation on them and because of the longer stay and longer metabolism in the body. So if Khalid is still seizing, he continued for the more than 20 minutes, received the benzos, and he's still seizing. So what will be the next step? So the most guidelines are now using phenytoin or phenytoin, levetiracetam or valproic acid. Other guidelines are using phenobarbital after phenytoin, and we have to be cautious using valproic acid in pediatric. Most studies now you can find or guidelines there they have removed phenobarbital from the second line treatment. However, I will show you a study that was done in Saudi Arabia and guidelines by Dr. Bashiri and his colleagues, and they have put phenobarbital as a second line according to the CPG guidelines they have and protocol they have provided. However, still, this is by American Epilepsy Society. They have phenytoin, valproic acid, and levetiracetam to be done as IV. And in the New England Journal New England of Medicine, this study was published in 2019, and they found that is no significant difference in the rates of seizure cessation or safety between levetiracetam, phenytoin, and valproate. However, in the most there are so many centers in Saudi Arabia that they don't have IV levetiracetam. So therefore, after using phenytoin or phenytoin, because even phenytoin is not available in most centers, they can use phenobarbital according to Saudi Arabia guidelines. As I mentioned, in pediatrics, we have to be very cautious using valproate, especially in below 2 years of age, or a patient with developmental regression with unknown etiology. So if the patient is still seizing, we have reached now 40 minutes and the patient is still seizing. What will be next? So at this time, this is the time of PICU consultation, neurology consultation, and considering a continuous EEG. There is no actually clear evidence or guidelines for the therapy in this phase. Most of them are level U, so you can choose between repeating the second line, giving a thiopental, phenobarbital, ketamine, midazolam, or propofol, using especially continuous EEG monitoring as you are putting the patient in coma. So it depends on the center, depends on the available medication. One or a doctor can use the available resources. So what is status epilepticus? Actually, status epilepticus is a condition when seizures are abnormally prolonged. After a point time T1, it can have long-term consequences after time point T2, including neuronal death, neuronal injury, and alteration of neuronal networks depending on the type and duration of seizure. Seizure types either continuous clinical and or electrographic seizures activity or recurrent seizure activity without recovery, returning to baseline. It's very important to differentiate between T1 and T2. As a first time point T1, which is the 5 minutes in the definition, is the time which ongoing seizure activity should be regarded as abnormally prolonged and likely to stop spontaneously, and when treatment for status epilepticus should be started. So this definition was invented for management purposes, not to delay the management after 5 minutes, as the longer duration of the seizure, the least likely to be aborted. T2, the second time point, which is 30 minutes, is the time where ongoing seizure activity poses significant risk of long-term complication. Convulsive status epilepticus is defined as a convulsion that are associated with rhythmic jerking movement of extremities or other parts of the body. Non-convulsive status, where is neurological symptoms and sign other than convulsive is not seen. A refractory status epilepticus, which usually they don't respond first to anti-seizure medication. So in more definition, like to talk about or to define status epilepticus. In generalized tonic-clonic seizure, T1 is 5 minutes and T2 is 30 minutes. In focal seizure, it's 10 minutes, T1, and time 2 is 60 minutes. Absent seizure, more than 15 minutes is T1, and T2 is unknown. So what will happen? So this is time-related complication of status epilepticus, where below 30 minutes there will be increased blood pressure, decreased oxygenation, and there will be decreased pH, increase in the temperature. Then some autonomic disturbances start to have like a pulmonary edema, increased potassium, and however, normal CK. With the starting of increased cerebral blood flow and cerebral metabolic oxygen consumption. The longer time, they will have lower blood pressure, which cause hypotension. Decreased arterial oxygenation will cause hypoxia. Increased arterial CO2 will lead to increased ICP, acidosis, then increase metabolism or oxygen consumption. Then autonomic activity will lead to arrhythmias, lung fluid accumulation will lead to edema, pulmonary edema, then hyperkalemia, rhabdomyolysis, and acute renal failure. With increased cerebral blood flow will increase risk of bleeding with intracerebral hemorrhage, and cerebral metabolic oxygen consumption will lead to ischemia. So all these complications are likely to happen if the seizure was not accorded after 30 minutes. And why is that? So this is the pathophysiology of status epilepticus, where on neurochemical level, seizures are sustained by excessive excitation and reduced inhibition. So there will be excessive excitation, there will be no inhibition. So as you know that glutamate is the most common excitatory neurotransmitter, and lambda receptor subtype is involved in glutamate receptor. GABA receptor is the most common inhibitory in neurotransmitters. And a failure of inhibition process is increasing through inhibitory lack of inhibition that will lead to a major mechanism of status epilepticus. So it's either increased excitation or lack of inhibition. This, however, also change in gene expression that are induced by status epilepticus result in alteration in number or of subunit composition of ion channels, receptors, cells, metabolism, and neuronal connectivity. So this will lead to neuronal death from inability to handle large increased intracellular calcium. And then this will, which actually happen because of prolonged exposure to excitatory neurotransmitter. So the more prolonged status, the more poor prognosis. So what is the incidence of status epilepticus? There is actually bimodal age of distribution with peaks during infancy and elderly. And as pediatrician, we see the infancy status epilepticus is very common. It is from 7 to 40 cases per 1,000 person per year. And it's more common in males. Usually it can be seen however, mostly when it is seen in children or adults, there will be a history of epilepsy in the past. Short-term mortality within 30 days of status epilepticus from 7 to 20% across all age group, and is more in elderly. The etiological factor is many. There is acute and chronic. Acute causes such as sepsis, sinus infection, strokes, heat trauma, drug-induced hypoxia, post-Rx or hypertension, encephalopathy, or autoimmune encephalitis. Chronic causes such as pre-existing epilepsy, chronic alcohol abuse, CNS tumors, remote CNS pathology, or acute symptomatic. It's seen more in younger children. Prolonged febrile seizure more so also seen in children. CNS infection also seen in children and immune compromised patients. This study was published by National Guard Center and was at that time by students who are now one of our senior residents to see the prognosis and of status epilepticus and the etiology over 10 years with analyzing 116 patients, and they found that remote symptomatic etiology was most common cause of status epilepticus, and these with remote and the prognosis usually was the predictor of outcome is the underlying symptomatic etiology of status epilepticus. This is another study done by for Dr. Reem Al-Yobi and her colleague in Jeddah. And as you can see that the etiology of status epilepticus in analyzing 88 kids, mostly prolonged febrile seizure, and then electrolytes imbalance and unspecific causes, such as also sinus infection, tumors, trauma, hydrocephalus, and hemorrhagic strokes. So usually if the patients come with status epilepticus, all patients should have a finger stick glucose to monitor their vital signs, brain CT, especially if it was the first attack of status epilepticus, to order electrolytes, CBC, EEG sometimes is needed, especially in refractory ones. Consider LP, MRI, and toxicology screening and other lab according to the history and examination. So in this slide, this is the algorithm that is established by American Epilepsy Society and in 2016. And you can see that the second line is, as I showed you, phenytoin, levetiracetam, or valproic acid. This was established as a CBG for convulsed status epilepticus in children in Saudi Arabia by Dr. Bashiri and his colleague. And first line is benzodiazepine as all recommendation. However, you can see in second line that they recommended phenobarbital, added phenobarb in the second line in addition to the non-phenytoin, levetiracetam, and valproic acid, and then PICU, as we mentioned, midazolam, thiopentol, phenobarbital. So in summary, status epilepticus is a medical emergency. Failure to manage it early might lead to morbidities and mortalities. Having a protocol in each center would prevent delayed treatment. Thank you. Any questions?
Thank you, Dr. Baarma, for this nice talk and important talk as well. Dr. Sulaiman Al-Mubarak, can we proceed for the next?
Yes, sure.
Okay. Dr. Sulaiman Al-Mubarak is a consultant of pediatric neurology with neuromuscular and neurogenetic subspecialty working at King Faisal Specialist Hospital, Riyadh. He graduated from Saudi Board of Pediatric Neurology 2017 and then completed his fellowship in neuromuscular disorder and EMG from SickKids Canada, followed by a fellowship in neurogenetics from McGill University, Montreal, Canada in 2021. Dr. Sulaiman Mubarak today will talk about acute ataxia. Welcome, Dr. Sulaiman.
Thank you. Can you see my slide?
Yes, clear.
Okay. Thank you, Dr. Adina, for your nice introduction, and thank you for the organizer for having me to present this talk. I know we are in almost end of the day, so I will try to tighten it up as much as I can. So today I would like to talk about the diagnostic approach of ataxia. And so my talks will be divided into 3 parts. What is the ataxia? Second, I will show the diagnostic approach of acute subacute. Third, I think it's worth to mention the chronic progressive ataxia and the approach for it. I will try to make it as simple as we can. So let's begin with our first talk. Ataxia is, what is ataxia? So ataxia is derived from Greek, meaning without orders. As such, it is a broad, non-specific description. So people with ataxia, they will show impaired movements in terms of timing, extent, and variability. There are 4 types of ataxia, namely as frontal lobe ataxia, vestibular ataxia, sensory ataxia, and cerebellar ataxia. So as you can see here in the diagram, the cerebellar integrate with the frontal lobe, with the proprioception information, vestibular information. So this different anatomical involvement will show the same gait ataxia. So we need, what is the clinical difference among cerebellar versus sensory versus vestibular ataxia? So here, if you can see, this is the table that can show you what is the clinical difference among the 3 main types, the cerebellar, sensory, and vestibular ataxia. So in cerebellar ataxia, patient is often unable to stand with feet together, even with eye opening. Romberg test is generally absent, although there is some corrosive about that. We will come to it later. In patients with sensory ataxia, impaired position sense and absent ankle reflexes are characteristic with positive Romberg's test. In the vestibular ataxia, patient will not show limb ataxia, but will show characteristic nystagmus. The slowing of walking generally is a characteristic keywords for the frontal lobe ataxia. So for Romberg test, I want to emphasize the importance of the Romberg test. As you all know, the 3 sensory symptoms provide their input to cerebellum to maintain truncal stability with eye opening, including vision, proprioception, and vestibular sense. 2 of 3 systems are needed to maintain the balance. I would like to show you here the representative procedures and the case, how we are applying the Romberg test. So the patient is asked to stand with both feet together. So the clinician asks the patient to first stand quietly with eye opens, then with eye closed. So the patient tries to keep his balance. in case if there is any sensory disturbance or deep sensory disturbance, usually he will lose his balance and fall. Again, it is crucial to understand the difference between sensory ataxia and cerebellar ataxia in Romberg test. Here in the first figure, it showed the Romberg test with sensory ataxia, which is most of us familiar with. So during the eye opening, the patient can keep standing steadily without any issues. With eye closed, the patient stand unsteadily, wobbling and falling. Interestingly, with the Romberg test, in the patient with cerebellar ataxia may show instability. So the patient, he will wear unstable to stand steadily whenever their eyes were closed or open, and they tend toward the disease side of the cerebellum. So again, the Romberg test with the patient with cerebellar ataxia, they showed that the patients will be unstable or unable to stand steadily, whether the eye is closed and open, and usually they tend to tilt toward the disease side of the cerebellum. To elaborate more, it's very important to understand the anatomy and topo diagnosis of the cerebellum. The cerebellum is usually separated into the midline cerebellum and the cerebellar hemisphere. The involvement of the vermis over here lead to ataxia of balance, gait, and dysmetric saccadic eye movements. Involvement of hemisphere, it will lead to the ataxia of ipsilateral limb movements. There is also follicular loop. It's not very clear here, but if it's involved, they will lead to ataxia of balance, gait, and saccadic smooth pursuit. And more important, it will lead to the suppression of vestibulo-ocular reflex, either the suppression or maybe reduced in the gain or maybe impaired of the VOR adaptation. Here to make it more simple, so if we have an impaired in the vermis or lesion in the vermis, we will have gait ataxia, truncal ataxia, or trunk ataxia. These are three abnormal eye movements. If we do have a lesion in the hemisphere, depending on the site of hemisphere, but they usually will have ipsilateral limb ataxia, dysmetria, intention tremor, dysdiadokinesia, and limb hypotonia. So some general definitions, I think it's good to elaborate it here. The ataxia, when we say the ataxia, as we mentioned before, it's mean impaired coordination. When we are saying dysmetria, that's mean undershooting, maybe, yeah, undershooting or maybe overshoot of intended position. Dysdiadokinesia, it's mean impaired of rapid alternating movement. However, in case of you in doubt or you cannot know what you are facing, just describe what you see. Having said that, why would someone with cerebellar ataxia have normal appearing cerebellum on the brain MRI? So you don't actually need to have a lesion in the cerebellum itself to cause cerebellar symptoms and signs. Disturbing connection to or from the cerebellum can have the same results. This occurs with a certain types of spinocerebellar ataxia, or maybe if there is any lesion or infract in the thalamocortical or thalamocapsular lacunar infraction, it can cause the same. One thing I would like to mention also during the physical exam, you are to assess the cerebellum. We are always doing them. We are always do the eye exam. And we are commenting on two things, either nystagmus or the saccade movements. What is the nystagmus? So nystagmus occur, or why the nystagmus is happening with the cerebellum? Nystagmus occur because the cerebellum is also involved in the coordinated contraction of intraocular muscle, which is necessarily to hold the gaze in one position. If there is a cerebellar injury, the eyes drift off the targets. So there will be a cortex, they will initiate the fast corrective movements. Let me play this to make it more easier. So as you can see, he is going to ask the patient to see his right finger and he will do the horizontal gaze exam. Again, the cerebellum is involved in coordinated the contraction of extraocular muscle. So if there is a cerebellar injury, the eyes drift off the target, and there will be a correction which cause fast corrective maneuver or movements. So maybe it's settled here and there. Here it's more clear. The fast corrective maneuver because if there is a cerebellar injury. This is regarding the nystagmus. The saccade movements. What is the saccade movements? The saccade movement is a smooth pursue movement. That means the person cannot track a target with one continuous smooth movement. Let me open this first. So we will put two objects in front of the patient and ask the patient to see the two objects alternatively. As you can see here, she will see here and there, and will keep going. This is what we call it the smooth pursue or saccade movement. Some people will have abnormalities in case of what? If there is a delay in this movement, if there is a jerky or jerky pursue movement, this indicates there is injury of cerebellum. Both of this exam is totally normal. So the sign that suggests physiological disorder: delay, slow movement, disconjugate or overshooting. Okay, so there is a recently there is several authors proposed that the importance of concept of cerebellar cognitive affective syndrome. What does that mean? So as you can see, the healthy cerebellum are related not only to the movements, but also emotion and congestion will be affected. What we call it the universal cerebellar transform. So with cerebellar injury, patient will not show only the dysmetry of movements, they could have a dysmetry of thoughts, or what we call it the cerebellar cognitive affected syndrome. So in the simple words, that the patients with cerebellum, they could have cerebellum cognitive affected syndrome. That means there will be impairment in his executive function, in his emotion, in his language, over and above the speech, speech. To emphasize this more, this is the imaging evidence that there is for the novel concept of the cerebellar cognitive affective syndrome. A VBM study, this is I think is an MRI study, and it shows the anatomical structure for the cerebellum. Showed the location, the VBM heinous study here showed the location of the lesion determined motor versus cognitive. In the motor, usually the cerebellar motor syndrome, the patient will have damage to the anterior lobe region only, in the anterior lobe region, as you can see here. In contrast, with the cerebellar cognitive affected syndrome, the lesion will be in the posterior lobe. I won't go to the other concept about the basal ganglia and cerebellum related, which is the integrated networks, and there is some new concepts or hypotheses they are implementing here. My idea here just to mention that if there is a midline anterior cerebellum, it has an important motor function, but the posterior is not, and you could have the cognitive impairment like executive function, emotion distress, and etc. So about the first part, to conclude our first part, the ataxia is defined as impaired coordination of voluntary muscle movement, cerebellum and its afferent and efferent connections, the frontal lobe, the vestibular system, and proprioception sensory pathway all can be involved in the ataxia. It is crucial to understand the correlation between neuroanatomy and clinical feature of ataxia. Presence or absence of dysarthria scan, or what we call it scanning speech, and Romberg test will be useful for differentiating among cerebellar, sensory, and vestibular ataxia. Cerebellum is usually separated into midline cerebellum and cerebellar hemisphere. The cerebellum will be associated with cognitive and affective syndrome. let's move to the next talk about the acute and subacute ataxia. So the time course of acute ataxia, usually over a period of minutes to days. The most common causes, as you can see here, it could be vascular, intoxications, infection, vascular such as cerebellar ischemia, cerebellar hemorrhage, infection. It's subcategorized further to cerebellitis or cerebellar abscess or meningitis. Intoxication with the drugs like anti-epileptic drugs, some of them chemotherapy, lithium, metronidazole, amiodarone can cause those. Toxic agents like mercury and some of the pesticides can cause ataxia or acute ataxia, and alcohol, of course, one of them. So infection of the cerebellum, it can cause both, actually, acute and subacute. To elaborate more here, we will talk about the acute first. The acute causes or acute infection that can cause, the infection that can cause acute ataxia, most probably it will be viral. And some studies, they state that in the young children, viral and post-viral ataxia, they are the most common cause of for acute ataxia. In the children, the most common virus is varicella. In the adult, ABV virus. Here are the list of the infection can cause chronic ataxia: neurosyphilis, Lyme disease, Whipple, HIV, and CJD. CJD more with adult. Neurosyphilis can cause purely sensory ataxia. Lyme disease, it's rarely, but it could cause cerebellar ataxia. Whipple, 50% of those patients with they could have CNS symptoms with cerebellar ataxia. HIV, of course, it can cause if there is a focus cerebellar region. After moving from acute, now we will go to the subacute, and usually the course between days to weeks. And the acronym I am using, it's SEPIN. SEPIN, that stands for systemic disorders, autoimmune disorders, paraneoplastic, infectious, and nutritional disorder. Systemic disorders such as acquired hepatocerebral degeneration, hypoparathyroidism, superficial siderosis, autoimmune disorders such as multiple sclerosis, ADEM, GAD antibodies, celiac disease, Hashimoto. Paraneoplastic antibodies should be considered. Infectious, like what we mentioned before, the chronic causes, such as those, can cause subacute to chronic ataxia. Nutritional disorder, which is a vitamin deficiency, especially E, vitamin B1, and B12. Okay. An approach to ataxia, it is like any other case. We will start with history and exam, then we will go to the lab, or blood workup, or the lab investigation, after that imaging, and further. Those are the most common, or let's say the most relevant questions we need to ask for the patients. What is the onset? Is there any progression? What is the type of ataxia? Sensory, vestibular, cerebellar? Is there any family history? Is there any suggestion of acquired ataxia? Drug history, alcohol, stroke, MS, infection, and etc. Is there any associated features, other features? Here's some clue. If there is a macular degeneration in the exam, this will lead to narrow the diagnosis to spinocerebellar ataxia 7. We will come through that. If it's isolated ataxia, think about the sporadic type of ataxia. The most common one is spinocerebellar ataxia type 6. If it is fast progression, two things, keep it in your mind: paraneoplastic and infectious. If there is diarrhea, think about the vitamin E deficiencies or Whipple. If there is autonomic failure, think about the multiple system atrophy or Fragile X associated tremors. This is more with adult onset, to be honest. Lab need to be done with ataxic patients: liver enzymes, parathyroid hormone, thyroid function test, vitamin B1, B12, and E. Paraneoplastic antibodies like anti-U, anti-RI, anti-WHO, and etc. Serological testing for infectious workup, albumin, alpha-fetoprotein for ataxia telangiectasia, cholesterol level for beta lipoproteinemia, seroplasmin and serum copper for Wilson disease, and ANA and autoimmune screening, either in the blood or in the CSF as well. Of course, imaging is also very useful tools for approaching the ataxic patients. MRI head plus minus spine, and it's better to consider pan-CT, especially if you are if the paraneoplastic is a possibility or a consideration, one of the possible differential diagnosis, and you may repeat it to don't miss the possibility of malignancy. Okay, let's apply this to our patients or our approach. So the screening tools, or summarizing the screening methods for acute ataxia, as we mentioned earlier, we will do the general examination, then history of causative drugs or such as alcohol and toxin, and we are going to ask those relevant questions that we mentioned earlier. Then we will do the blood test, ECG, chest X-ray. All these will be a useful information. MRI always is a useful. However, some limitations we need to keep it in mind. Posterior circulation territory in DWI, diffusion weighted imaging, showed negative signal changes due to small lesion size or maybe insufficiency for signal to noise ratio. So we should keep it in mind. We may have false positive result when we are applying MRI, especially in the posterior and posterior brain. If you face an abnormal finding of MRI that's not consistent with the vascular territory, you should think about the infectious causes, such as mycoplasma, tuberculosis, and listeriosis. Here we are moving to the subacute causes. Again, we will do the physical exam, the history questions, then we will go to the blood test. We will ask for electrolytes, ammonia, liver function test, copper, ceruloplasmin, lactate, pyruvate if we are suspecting systemic disorders, GAD, NA, and etc. if we are suspecting autoimmune disorders, anti-WHO, RI, MA, and YO for the paraneoplastic syndromes, and infectious workup if we are suspecting infection, liver function, ammonia, and vitamin B levels, B1, B12, and E if we are suspecting nutritional disorders. Again, the MRI and CT will provide a useful information for diagnosis of subacute cerebellar ataxia. As you can see here, hypothyroidism, GC virus infection, Wernicke's encephalopathy, dura mater graft associated CJD, and neurosyphilis, CNS lymphoma. All of them, they maybe have a characteristic MRI finding. So that will show you how important we should order an MRI in most of our ataxic patients. Interestingly, that autoimmune-related subacute cerebellar ataxia, they often showed a pure, mild to moderate cerebellar atrophy. It will be the only finding in the MRI brain. Keep this in your mind. So the take-home message from the acute and subacute ataxia: when we see a patient with acute cerebellar ataxia, vascular, toxic, and infectious causes should be considered. Systemic, autoimmune, paraneoplastic, infectious, and nutrition disorder should be considered as a cause of subacute cerebellar ataxia. MRI and CT can provide a useful information in the differential diagnosis of subacute cerebellar ataxia. Patient with subacute ataxia due to autoimmune abnormality can often show abnormal finding confined to the cerebellar MRI, like what we are mentioning. It's mild atrophy of the cerebellum. Patients with subacute cerebellar ataxia often have a background condition that need to be treated, either infectious or maybe vitamins and etc. Finally, I would like to discuss about the diagnostic approach of chronic progressive ataxia. If we look to chronic progressive ataxia, we should consider the hereditary ataxia, which including autosomal dominant cerebellar ataxia, autosomal recessive cerebellar ataxia, X-linked ataxia, mitochondrial ataxia. Autosomal dominant, they under umbrella or what we call it spinocerebellar ataxia, SCA, and also episodic ataxia under the autosomal dominant type. Autosomal recessive ataxia, the examples like Friedreich ataxia, ataxia-telangiectasia, ataxia with oculomotor apraxia, hereditary vitamin E deficiency, and many others. X-linked ataxia, it is the fragile X-associated tremors, one of the example. Mitochondrial ataxia, such as MELAS, MERVS, NARBI, it could be an example of the mitochondrial ataxia. So it's important to make sense what is the spinocerebellar ataxia when we are saying about here the dominant type. So even nowadays, Harding classification of autosomal dominant cerebellar ataxia in 1982, it's still useful in a clinical setting. Autosomal dominant cerebellar ataxia type 1 is a cerebellar ataxia with variable additional sign. In other words, if you found cerebellar ataxia with variable additional sign, think about those type. In the ADCA or autosomal dominant cerebellar ataxia 2, if you find a patient cerebellar ataxia with pigmentary macular degeneration, think about spinocerebellar ataxia 7. If you ADCA 3, which or autosomal dominant cerebellar ataxia 3, usually they will be pure cerebellar ataxia syndrome. So if you found a patient or see a patient with a pure cerebellar ataxia syndrome, think about those types. Although several studies showed that this classification, some of those patients show non-cerebellar ataxia symptoms. So it's somehow a tool to help, but it's always there is an exception, or always there is a typical presentation. Spinocerebellar ataxia, or the dominant type. This is the diagram showing the geographic distribution of spinocerebellar ataxia. As you can see here, the spinocerebellar ataxia 3, it's almost the most common polygothumine CSA worldwide, accounting up to 20 to 50% of family with dominant ataxia. Owing lack of the systemic details, the prevalence and geographic distribution of other spinocerebellar ataxia or non-coding expansion are still fragmentary. The ones in the, I mean, the ones in the yellow boxes. So back to our autosomal dominant type, there is many classifications, but it is the two main umbrella we can consider it: spinocerebellar ataxia or episodic ataxia. Spinocerebellar ataxia is almost up to now it's 48 types. Episodic ataxia it's 7 types or 8 types from 1 to 7. Both of them, or many of them, or most of the dominant type, clinically and genetically heterogeneous. They will have a cerebellar ataxia associated with other neurological sign, pyramidal sign, extrapyramidal sign, ophthalmoplegia, and cognitive impairment. The onset for the dominant type usually during the 3rd or 4th decade, but wide range, it's possible, and it could happen earlier. Spinocerebellar ataxia 1 and 2 and 3, 1, 2, 3, and 6. I think yes, 1, 2, 3, and 6. Those are the most common types, and usually they will be a wheelchair by 10 to 15 years after the symptoms onset. No effective treatments is available in general for the spinocerebellar ataxia. Episodic ataxia, again, as we mentioned, it's heterogeneous. Usually they will have a paroxysmal disorders and present in the childhood. Episodic ataxia type 1 and 2, it's count for the majority of the cases. And 50% of them, they will have migraine headache. The treatment with acetorezulamide, it could show some benefits. Now we will move to the autosomal recessive type of cerebellar ataxia. They are heterogeneous group of the disease. The age of onset usually before the age of 20. The most common of these are Friedreich ataxia and ataxia-telangiectasia. So the Friedreich ataxia, it is the most common type. It will, the result, the pathophysiology or the pathology here is loss of function, mutation in the frataxin gene. The vast majority, or more than 90% of the patients, they will have expansion trinucleotide repeat of the GAA. So the severity and the rate of progression depend how much of the repeated expansion. More the repeated expansion, more severe for it phenotype. So the mean age of onset 15 years, they will be wheelchair bound by the average of 11 years after the onset, and the life expectancy 35 to 40. This is a very common question. You're gonna hear it if you are labeled any patient with the Friedreich ataxia, the life expectancy. We shouldn't miss the treatable cause of the autosomal dominant autosomal recessive type of ataxia. Ataxia with isolated vitamin E deficiency, yearly supplementation with high dose of vitamin, it's associated with better outcomes. The same goes with beta-lipoproteinemia. Also, all these an example of autosomal recessive. Also, the cerebrotendinous xanthomatosis. Early initiation of therapy of this acid, chindoxylic acid, it's effective at preventing further deterioration. Refsum disease, strict reduction in dietary phthalic acid intake may be associated with significant improvement in both, not only ataxia, also for the peripheral neuropathy. Also, the coenzyme Q10 deficiency with cerebellar ataxia, supplementation of Q10, it will help them. So in other words, if you are suspecting of those, you can just do the trial. You can try the vitamin E, Q10, whatever the available resource you have it in your hospital. Again, MRI for diagnosis of autosomal recessive is also important. Friedreich ataxia, patients show significant atrophy changes in the cervical spinal cord. Wilson disease show characteristic of signal changes in the midbrain, or what we are calling panda appearance. Cerebrotendinous xanthomatosis will show increased signal intensity in dentated nucleus in the cerebellum. And the Fragile X tremor ataxia, they will show increased signal intensity in the middle cerebellar peduncle in T2 weighted imaging. So it's very useful tool to detect or to narrow your differential. So another common question, should we order a proceed for whole exome sequence for patients with ataxia? As we mentioned earlier, many different hereditary ataxia like spinocerebellar 1, 2, 3, 6, Friedreich ataxia, FXTAS, most of them are, or many of them, or most of them are trinucleotide repeats. That means it cannot be detected by whole exome sequence. So it will be missed by whole exome sequence. We should order a specific panel for them in case of to diagnose them. So to wrap up, this is another way of differential diagnosis. Instead of make it acute, subacute, or chronic, we can label it as acquired or hereditary and degeneratives. Acquired, we have common and uncommon. Common, we have chronic alcohol, drugs, viral, paraneoplastic, multiple sclerosis. Uncommon, we have vitamin deficiencies, anti-GAD, steroid responsive or Hashimoto, and the infectious cause that can cause the chronic ataxia. Hereditary, as we mentioned earlier, autosomal recessive type, autosomal dominant type, X-linked, and mitochondrial. The degenerative type, we have two, multiple system atrophy and olivo-pontocerebellar atrophy. This is more with adult age or adult onset. Just one slide about it. Multiple system atrophy, it used to be 3 diseases. 5
minutes more.
Sure, I'm almost done. So multiple system atrophy used to be 3 diseases, autonomic disease, cerebellar disease, and Parkinson's. Most people will start one of these conditions, and eventually they will progress to develop symptoms of all 3. So they are now grouped together to be as a one disorder, MSA. Although olivo-pontocerebellar atrophy can still exist as a unique entity without a progression to MSA. So the take-home message from the part 3, the proportion of spinocerebellar ataxia disease is similar between countries. Characteristic if MRI finding can provide a useful information to consider the diagnosis of autosomal recessive types. In case of cerebellar ataxia with autonomic failure, the diagnosis of SMA should be considered. It's unnecessary to differentiate spinocerebellar ataxia. By this, I will conclude my talk, and thank you for your listening.
Thank you, Dr. Suleiman, for this informative talk. Our next speaker is Dr. Baligh Ali. Dr. Baligh Ali, he will talk about one of the emergency disorder in pediatric neurology, which is acute flaccid paralysis. Dr. Baligh is a consultant of pediatric neurology at King Saud Medical City in Riyadh. He's a director of pediatric neurology residency program in King Saud Medical City too. He's assistant clinical professor of pediatric neurology at Imam Muhammad Ibn Saud Islamic University and Al Ma'arif University in Riyadh. Dr. Baligh achieved Jordanian Board for Pediatric and Arab Board for Pediatric 2002 and 2006. He did fellowship in pediatric neurology at King Faisal Specialist Hospital and Research Center. Welcome, Dr. Baligh.
Thank you, Chairman and everyone for inviting me to this talk. Let me just try to share my screen, and then we can be on our way. Share screen. Okay. So check. Can you hear my voice clearly? Can you see the screen?
Yes, everything is clear.
Okay, sure. So today's talk is going to be acute flaccid paralysis, which, as you've mentioned, is one of the emergencies in pediatric neurology. I have nothing to declare, and I thank the organizing committee for inviting me to give this talk. The talk is comprised of 4 parts. Mainly, we'll talk as an introduction about the acute flaccid paralysis, and then we'll go into the list of causes, which is quite large. Maybe speak a little bit about pathophysiology and some scientific facts, and then we will wrap our presentation by giving you some take-home messages. So acute flaccid paralysis, it's comprised of 3 words. Acute means sudden, or as opposed to chronic or subacute. Flaccid is as opposite to spastic or dystonic, and paralysis is loss of muscle power or the ability to move. So it's essentially a clinical diagnosis, which means something like jaundice. If you see a child with jaundice, you say jaundice. This is a clinical diagnosis. If you see someone with backache, you say chronic backache, for example. It's a clinical diagnosis, and it does not refer to a certain disease. So it is a collection of signs and symptoms and not a definite diagnosis per se. The patient may come to the emergency room with an acute flaccid paralysis, which should be dealt with in an emergency situation and not labeled as the final diagnosis. So we've gone through this. And there are many causes, whether infectious or non-infectious causes, and we'll try to summarize them quickly. And the importance of this is because early intervention in some of them will give good response, and some of them might be critical, affecting the respiration by either affecting the respiratory muscle or higher up. This is just to show you how huge the list is. We will not be able to go over all of these lists, but I've just colored some of the important ones, like, for example, brainstem stroke can give you acute flaccid paralysis. Encephalitis can give you that. Poliomyelitis still remains to be a notorious culprit that people are trying to catch. Myelopathies, tumors, Guillain-Barré, of course, everyone's favorite diagnosis. Toxic, stick paralysis, the list is quite large. So let's go over them. And just to mention, one of the important ones are venomous snakes. And this is just to give you an example of the 3 most notorious types. They can give you complete flaccid paralysis because of the neurotoxin they inject by snake bite. Organophosphorus poisoning, again, we see this very infrequently, alhamdulillah, which is something good. If you remember, something like 15 years ago, there was a new type of organophosphorus agent in the market, and families started using them, and we saw a lot of cases that resembled Guillain-Barré or caused acute flaccid paralysis. Some of them were even fatal. And after that, the regulation came that no one can go and buy these poisonous materials off the shelf. So it's only sold to companies. Some of the chemical warfare, such as VX and serine gas, can give you acute flaccid paralysis, Reye syndrome, and very rarely oral polio vaccine itself, especially in patients who are immunocompromised. In infants, we should always think of botulism, especially if there is involvement of the extraocular muscles and constipation, and if the family give you a history of giving the child honey. If ophthalmoplegia is there, then we should think of myasthenia gravis, and you will notice fatigability on examination, of course, in history, and nerve conduction velocity and EMG will always help us distinguish between these conditions, and of course the tensilon test. Clearly, hypothyroidism can affect the consumption and restoration of equilibrium of the potassium ions in neurons, resulting in hypokalemic paralysis. Acute neuropathies causing predominantly motor neuropathies such as lead, heavy metals, or vincristine. Let me rearrange this, because lead is no longer easily incorporated in industries such as in paints. It has been banned for the past few decades, so that's why it has come down on the list. And vincristine, we are starting to see more cases of vincristine neuropathies, especially in tertiary care centers where patients are receiving this medication. This is a very small insect which we don't commonly see in the Riyadh region. However, you see this biting and the head has gone in. This is tick, and it causes tick paralysis. And in any patient who had presented to you with ascending paralysis, you should, especially in children, in which you have labeled as Guillain-Barré, you should always undress the child and look for these very small insects. In the North American variants, they say that the response is very dramatic once you remove the tick. However, this dramatic improvement has not been replicated in other variants. Just to show you how big a tick is, these are three groups: the deer tick, the dog, and the other. So many types of these insects are found. Another cause of acute flaccid paralysis is diphtheria, especially if the patient is not fully immunized. Following the diphtheria, a patient may go into have this weakness, and you should always ask about recent history of pharyngitis, as we usually do. We spoke about polio and acute flaccid paralysis, and we have a national surveillance program supervised by the Ministry of Health, in which they try to pick up cases of poliomyelitis. So any case of acute flaccid paralysis, especially Guillain-Barré, it should be reported. And if you don't report it, the nurses usually do, and the health inspector usually passes by, and they collect 2 stool samples, and they do assessment upon admission, and then after 60 days, all this to try to identify the virus if found. The virus, the patients with polio can be divided into 2 groups, either caused by the vaccine, as we've mentioned, or it could be the wild variant if the patient is either not immunized or he has a failure of immunization in which the body does not respond to immune responses. And for that, you need some advanced testing to know which type is it. After they've identified this, they try to see if there is any outbreak, and they go door to door and try to strengthen the immunization in that area. Transverse myelitis, or acute flaccid myelitis, again, is one of the most important differential diagnoses that we see. It is 10 times less common than Guillain-Barré, an inflammation that spans across both sides, or at least one segment of the spinal cord. The inflammation leads to injury of the myelin sheath, which protects the nerves, leading to the flaccid paralysis. It's usually, it can evolve within days, but it's usually very quick, and it happens over hours. The initial symptoms usually include lower back pain and or sharp shooting sensation that radiates to the legs or arms if the lesion is high up. There is usually sensory level with sensory alterations, and transverse myelitis can cause paresthesia such as burning, tickling, pricking, numbness, coldness, or tingling sensation of the feet, and sensory loss. And of course, we have a sensory level. The name transverse myelitis is a misnomer because we know that the lesion may span over few segments of the spinal cord, as we've mentioned. These are what transverse myelitis causes: neuromyelitis optica, post-infectious and post-vaccinal myelitis. Transverse myelitis can also lead to multiple sclerosis, myelin, oligodendrocyte, glioprotein antibodies. Acute disseminated encephalomyelitis is a differential diagnosis of transverse myelitis. Cord lesions in neuromyelitis optica, Devic's disease, MOG antibodies, and CNS Sjogren's disease are longitudinal down the center of the cord. In multiple sclerosis, however, the lesions are usually shorter and eccentric. Cord symptoms evolve over hours to days, but usually what we see in pediatric is hours. But again, it might happen over a day or two, as opposed to Guillain-Barré, which may take a longer period in evolution. And they usually resolved over weeks to months. What we usually commonly do is give high doses of corticosteroids to hasten the recovery, but unfortunately does not have any effect on long-term outcome. The acute partial myelitis is more likely to progress to multiple sclerosis than the complete transverse myelitis. And hence, when you see an improvement and response in the corticosteroids, you should always follow the patient up, because this might have been the first attack the patient had developed. Of course, when then you do neuroimaging, CT, and MRI scan of the brain and the spinal cord. Compression of the spinal cord from abscess, herniation disc, synovial cyst, epidural or subdural hematoma, either spontaneous or after lumbar puncture, or trauma, tumors, tuberculomas, or atlantoaxial subluxation can be a differential diagnosis of transverse myelitis. That's why it's very, very important to do the neuroimaging to exclude this list of differential diagnosis. In 2 MRI lesions, they are quite commonly see at the site of disc herniation, about 30 to 40%. Of course, it depends on the severity of the compression. Those without T1 lesions have a better prognosis. Of those, the 2 lesions, about 1/3 to half of these patients improve after surgery, some by the end of surgery. Let's talk about Guillain-Barré. And people are talking about this disease for quite some time. It's a rapid onset of muscle weakness caused by an immune system damaging the peripheral nervous system. And I would like to take the word peripheral with a grain of salt, because it might also affect the central nervous system, as we will talk about. What happens is that B cells produce antibodies, and these antibodies not only attack the pathogens, but they also attack the nerve cells, causing the damage and hence the disease. The list of diagnostic workup is still mainly clinically oriented, so there is no specific test that would tell you, yes, this patient has Guillain-Barré, although Brighton criteria has come up in the last few years, and we'll talk about this shortly, to aid us in prognosticating the disease. But things that help us support the diagnosis of Guillain-Barré include nerve conduction studies, which have reduced signal, and then lumbar puncture, of course, which shows raised protein. But then you always tend to wait until the second week, because the protein rise does not happen suddenly, as we all know. And of course, there is a newer modality that we should always remember in diagnosing or working up patients with Guillain-Barré. We've just talked about it moments ago. MRI spine. Again, to rule out the differential diagnosis that we talked about moments ago. This is the MRI spine of a patient with Guillain-Barré. And in this typical findings, you see there are surface thickening and contrast enhancements of conus medullaris and the nerve roots of the coda equina. Just have a look again. You should always look at the axial cut as well to look for these enhancements. This is the Brighton criteria. The Brighton criteria are used as a tool to assess the diagnosis of Guillain-Barré and to help us distinguish between the low risk and high risk patients. They aid in the early and prompt diagnosis of the disease. The criteria also helps in outlining the course of treatment required by particular number of patients diagnosed with Guillain-Barré. You can find this table and much more information in a very interesting article published in 2019 in entitled Severe GBS Following Shingrix Vaccine Administration. It's an open access, and this is a rare complication, of course, of the vaccine, which is of course now available for patients, for people above the age of 50 in primary healthcare centers. I would highly recommend everyone to take it. So Guillain-Barré is rare. It's 1 in 100,000. It is an acquired immune-mediated radiculopolyneuropathy characterized by an ascending, and I've grayed out the word ascending because it's not always ascending. There are subtypes, and we'll talk about them. It's a progressive, yes, a progressive weakness, and areflexia. I should have grayed out also areflexia because areflexia is not unanimous or universal for patients with Guillain-Barré. So if you see a patient who has this picture, however, he still has the reflexes, presence of reflexes does not exclude Guillain-Barré. You may have sensory involvement in patients with Guillain-Barré. You may have autonomic involvement, and even brainstem changes have been seen. But primarily, it's a motor disease. The incidence, as I've mentioned, is from 0.5 to 1.5. So to round it up, it's 1 in 100,000, as opposed to patients with acute transverse myelitis, which is 1 in 1 million. Guillain-Barré is mainly affects adults. It's approximately 15% of children with Guillain-Barré develop the respiratory failure and require mechanical support and mechanical ventilatory support, which means 85% of children will not require this ventilation. One of the reasons being that we are very vigilant and quickly start the IVIG treatment, which usually prevents the patient from falling into this severe weakness. The weakness can also have some tingling sensation in hands and feet, and these tingling sensations might be the first symptom that you see. As I've mentioned just in the previous slide, Guillain-Barré syndrome has been more commonly seen in men over the age of 50, and that could be one of the reasons in which this was mentioned in this study, because patients who received the Shingrix vaccine, at least in Saudi Arabia, are those adults above the age of 50. So always take these information and scrutinize them, take them with a grain of salt. The pediatric presentation differs from adult presentation in that children are more commonly complain of sensory symptoms such as pain and gait instability manifested as gait ataxia, as mentioned by Dr. Al-Mubarak Sliman. We're coming towards the end of our presentation. Guillain-Barré syndrome is an acquired autoimmune mediated radiculopolyneuropathy characterized by an ascending progressive motor weakness and areflexia, although the areflexia is not a mandatory, but it's almost always there. Although weakness is the hallmark symptoms, differing presentation Different presentations in children as opposed to adults can include predominant symptoms of cataxia or pain, and a higher incidence of cranial nerve abnormalities. Regional differences is present and observed with demyelinating subtypes more prevalent in the Western countries, such as the United States, and the axonal subtypes more prevalent in Asia and Mexico. Most significant complication is the need of respiratory support, which is reported, like we've said, in almost 15%, so which is 10 to 30% of children. The most significant complication is the need for respiratory support, as we've mentioned. Children who, however, differ in their presentation from adults. Again, I think this is just a repeat. Further workup may reveal supportive evidence that such as the albino cytologic dissociation in the CSF, which is a fancy word that the protein will be high and the WBCs will be normal. Abnormalities in conduction velocities, the F waves, and the compound motor action potential in electrophysiological studies, and contrast enhancement of the nerve roots observed in lumbosacral MRI in the MRI picture that we've just seen. Variants of Guillain-Barré. So Guillain-Barré, again, you have at least 5 subtypes. The acute inflammatory demyelinating polyneuropathy, and this is the most common subtypes that we see. The acute motor and sensory axonal neuropathy, and then we have the acute motor axonal neuropathy. Miller-Fisher, again, we see this more commonly in pediatrics, and polyneuritis cranialis. Miller-Fisher, just a slide quickly on Miller-Fisher. This is a variant seen in children characterized by a triad of ophthalmoplegia, ataxia, and areflexia.
5 minutes remain, Dr. Baligh.
Okay, inshallah, we'll finish sooner. So areflexia, ataxia, and ophthalmoplegia associated with serum anti-GQ1B. Antibodies and MRI of the brain may reveal nerve enhancement specifically at the cranial nerves. Complications and prognosis: weakness of the respiratory muscle, 10 to 30% will require ventilation. Residual fatigue is reported after Guillain-Barré and may be related to more pronounced axonal subtype or axonal loss, which is usually the worst type. In general, about 90% will show full recovery, which is a good news. In a series of median time of onset of symptoms to the first recovery was between 17 to 37 days, and when about 66 days of seizure free. That's why the 60 days assessment in patients with polio was there, if you remember. And patients with axonal form have a poorer prognosis, as we've mentioned. The full recovery period is longer. The full recovery period is longer than the period of time that the children was sick, often requiring months of physiotherapy and follow-up, and usually it might reach up to 7 months of physiotherapy and follow-up. Although the majority of patients achieve their maximum amount of functional improvement within the first few months, it continues even later on. However, some patients may have paresthesia, unsteady gait, and painful hands or feet or fatigue. Thank you. And thank you, physicians, especially in the past couple of years, for being there for your patients.
Thank you, Dr. Baligh. It was a very nice and informative lecture. Now, by the end of this great scientific day, I would like to welcome Dr. Matar Al-Sihami. Dr. Al-Sihami is a consultant pediatric neurology at King Fahd Hospital, Al-Baha. He is a general director. He's a general director of academic affairs and training at MOH Al-Baha region, and he is a graduate of Saudi Pediatric Neurology Board from King Saud University Medical City, Riyadh, at 2020. Please, Dr. Sahimi, tell us how to face acute headache.
Thank you, Dr. Adina, and for the organizing committee for inviting me to give this topic. And I hope you will enjoy this topic by the end of the day as a science, not as a symptom or a disorder. Okay, we'll start acute headache in children. We'll start by our objective is introduction, then we'll talk about challenge of pediatric headache. Then we'll talk about the international classification of headache disorder, the last classification 2018, 3, and how to approach to a child with headache. Then we'll to talk about the summary. Introduction, the headache is the most common neurological complaint in pediatric population, defined as a pain located above the orbitomyelial line. The prevalence increasing with age, although 30 to 50% below the 12 year of age, and with after puberty become more to 60 to 80%. With more female predominant, the most common headache is a primary headache rather than a secondary, but can be provoked by a secondary. 20% of the headache disorder is or are recurrent. Why challenging the headache in pediatric? Due to many reasons. One of them is that the child as non-specific has, he didn't tell non-specific complaint, a limited verbal language ability, poor localizing quality, and usually associated with other illness. The children with headache are adversely affected in all areas of functioning, including school performance, emotional development, and physical health. Although I will add, as the child can he hide his complaint by playing or interact with others. This is the international classification of headache disorder. We have a primary headache, secondary headache, and painful cranial neuropathy. The primary headache, as we know, a migraine and tension type headache. This is the first two is the most commonest in pediatric population. The other trigeminal autonomic cephalgia like cluster headache or short-lasting unilateral neurology form headache with conjunctival tearing or with autonomic. This is less likely in a child group, age group. The secondary headache, we'll talk about it later on. A painful cranial headache, like we have trigeminal neuralgia, occipital neuralgia, and etc. The headache, the secondary headache, can be attributed to infection or trauma or other. This is some changes in the classification from the version 2 to the version 3. As the childhood periodic syndrome from version 2 changed to episodic syndrome that may be associated with migraine. This is in the classification 3. The before was basilar type migraine, now became migraine with brainstem aura as the basilar artery is unbroken. The other, as you see, etc., there is some changes that we have to know. But the most important is a migraine and tension type headache. As this, the first two is the most common. Primary headache, that means head pain, is due to the headache condition itself. The secondary headache, this is the head pain, is a symptom of underlying condition. Primary headache and secondary headache are not mutually exclusive. That is mean a patient with a primary headache disorder can have a primary headache exacerbated by a secondary etiology. However, when we consider the secondary etiology for the headache, if the patient presented with new headache or a headache that differ from their usual headache. This is an example for the secondary headache due to high ICP or due to space occupying lesion like a tumor or due to hydrocephalus, or like in idiopathic intracerebral hypertension with papilledema. Also, we have headache secondary to low CSF. This is usually post-LP with characteristic finding in MRI with brachiomeningeal enhancement. A headache can be due to infection like meningitis and encephalitis, and this is life-threatening, should be treated probably, and could be due to abscess or empyema, or due to systemic infection like flu. Headache can be due to epilepsy. The most famous example or familiar example of the epilepsy that presenting with a headache is the occipital lobe epilepsy headache, like in Nato or Glascom syndrome. Headache can be attributed to substance or its withdrawal, like exposure to carbon monoxide, histamine, or non-headache medication, or medication of a use headache, triptan, acetaminophen, or non-steroidal anti-inflammatory drug or opioid, or substance withdrawal like in caffeine, opioid, or estrogen. Here, the criteria for the medication of a use headache, that the headache must be 15 or more days per month in a patient with pre-existing headache disorder, regular use of the acute or symptomatic headache for 3 months and more, and subdivided as a category if a patient uses ergotamine, triptan, or combination of these analgesia for more than 10 days or more per month, or if a patient using simple analgesia like a paracetamol, acetaminophen, or ASA, or non-steroidal anti-inflammatory drug for 15 days or more, or any combination of above mentioned drug or one or more medication other than those mentioned above, taken for acute or symptomatic treatment for 10 days or above per month. The headache cannot be better accounted for by another ICHD-3 classification. Headache or facial pain attributed to the disorder of the cranium, neck, eye, ear, nose, or sinuses or teeth. This is a secondary headache, like here refractive error, or due to secondary glaucoma, or due to inflammation of the sclera, like in uveitis, or can be acute sinusitis. However, the secondary headache most frequently in children due to upper respiratory infection or viral infection. Here, to understand what we talk about in approach, we should know about the common clinical headache pattern, as we have acute headache due to infection, hemorrhage, trauma, toxin, or vascular, or acute recurrent episodic like a migraine, tension type headache, or trigeminal autonomic cephalgia, or seizure associated. Chronic progressive headache, this is like a high ICP or space occupying lesion, or like in hydrocephalus. Chronic non-progressive headache like tension type headache, or new daily persistent headache, or post-traumatic psychogenic or ocular refractory error. How to approach to a child with a headache? We have 5 steps. First step is a history taking and physical examination. Then step 2, we should identify red flag either in the history or physical exam. Why? To know what is the underlying cause for the secondary headache. Then step 3 will tailor upon what we found in the history exam and red flag. Step 4, if a patient has a primary headache, we should categorize which primary headache to treat as a general measure, abortive and preventive. Then we have a plan management and strategy. First step, history taking and physical exam. We'll talk about history taking. The history of a headache for a child should initially be obtained from the child to be confirmed by the caregiver. In a younger children, caregiver observation of a behavior can support the diagnostic criteria. Asking younger children to draw the headache may assist in the diagnosis when the child is not able to express the headache characteristic in words. This is the most important element to ask in the history, as the age at onset, as most of migraine start before the age of 10 years. Mode of onset, we should ask about if there is abrupt onset, to exclude like in thunderclap headache due to a hemorrhage. This is as a most emergency, or gradual onset. Then we should ask about what's the headache pattern, acute or acute recurrent, chronic progressive, or non-progressive daily. This will help us to determine the cause. Then how often does the headache occur? This, for example, migraine typically occurs 2 to 4 times per month. almost never happen daily. Chronic non-progressive occur 5 to 7 days per week, while in cluster headache typically occur 2 to 3 times per day for several months. How long does the headache last? Migraine typically lasts 2 to 3 hours in younger children and may last longer, up to 48 to 78 in adolescents. The duration of tension headache is variable, while in cluster headache usually lasts from 5 to 15 minutes, but may last up to 60 minutes. Then we should ask about, is there an aura or prodrome? As an aura prodrome is suggestive of migraine. However, if there is focal or repetitively located in the same side of the body, we should consider other differential rather than a headache, like a seizure or vascular or structural cause should be suspected. Then when do the headache occur? Headache that wake the child from sleep or occur on awakening may indicate increased intracranial pressure or a space occupying lesion. While inattention type headache typically occur in the late of the day. Then what is the headache quality? If it is throbbing, pulsating, dull aching, squeezing, like in migraine, has half a throbbing or pulsating quality, while in chronic non-progressive headache have squeezing pressure or tightness that wakes and wane, while in cluster headache have deep continuous pain. Then we should ask about where is the pain. This is important as occipital location may indicate posterior fossa neoplasm, but also may occur in basilar migraine or migraine with brainstem aura. Cluster headache are usually temporal or retroorbital. Localized pain also may suggest secondary etiology like in a sinusitis or otitis or dental abscess. Then we should ask about what brings the headache on or make it worse as exacerbating factor. This headache in the recumbent position or with straining falsalfa maneuver may indicate intracranial process. Migraine may be triggered by certain food, odor, or bright light, noise, or lack of sleep, or on a pubertal female. In adolescent, maybe due to menses. And while intention type headache can be worsened by stress, bright light, or strenuous activity. Then we should ask about what makes the headache go away. Migraine typically respond to analgesic medication, dark, quiet room, cold compress, or sleep. Chronic tension headache may respond to sleep, but not to analgesic medication. However, we should ask also about headache diarrhea, as this is important to know the risk factor, the exacerbating or relieving factor, as well as to categorize which patient has a headache and how respond to the treatment. Then we should ask about if there is any associated symptom. If a patient has a fever, may this indicate infection, or rarely can be due to hemorrhage. Stiff neck may indicate also meningitis or complicated pharyngitis. Localized pain, as we said, indicate local infection. Or if there is associated symptom like neurological deficit, ataxia, altered mental status, may indicate increased intracranial pressure or space occupying lesion. Do symptoms continue between the headache? This is if a persistence of symptom as a neurological symptom, nausea, vomiting between the headache episode is suggestive of increased intracranial pressure and or mass lesion. The resolution of symptom between the episode is characteristic of migraine headache. And then we ask about do the headache impair normal function? Example for school attendance, activity, and quality of life. This is determining for us the headache burden. As the children with chronic non-progressive headache had frequent school absence and impaired function. We have additional to ask about the information in the past medical history. Like certain underlying condition increase the likelihood of intracranial pathology, like in a patient with sickle cell, immunodeficiency, or a malignancy, or family history, or coagulopathy, or in a patient with neurocutaneous like NF1 or tuberous sclerosis. Then we should ask about medication and vitamin, as some medication cause headache include oral contraceptive, glucocorticoid, The most frequent example that we know medication associated with idiopathic intracranial hypertension include growth hormone, tetracycline, vitamin A with excess dose or withdrawal of glucocorticoid. Then we should ask about if there is any recent change in weight, vision, or sleep, exercise, or diet. This may precipitate the headache, may be associated with mood disorder. A change in a school or home environment may be a source of psychosocial stress. A family history of headache or neurological disorder, this like a migraine and some tumor and vascular malformation are heritable, as we know. Then we should ask about what the child and parent think is causing the pain. This is indicate their level of anxiety about the headache. Then lastly, we should ask about the mental health history, symptom, psychosocial stressor. If like in chronic non-progressive headache may be associated with depression or anxiety. A physical examination, we should go through physical examination, like in a general, look for general appearance of the patient. As the patient have altered mental status may indicate meningitis, encephalitis, or increased ICD or hypertensive encephalopathy. Vital sign, the most important to look for if there is a fever as suggestive of infection, or if there is a hypertension may cause a headache or be respond to increased intracranial pressure. Then we go through anthropometric measurement like a head circumference, weight, and height. As a patient with obese, this usually with idiopathic intracranial hypertension, then we should auscultate for the neck, eye, and head, and for BROI, like in FAM malformation. Palpation of the head and neck, as may indicate there is a underlying etiology in tenderness of the patient, like a half if localized scalp tenderness may indicate migraine or tension type. If the patient has swelling may indicate trauma, or sinus tenderness may indicate sinusitis. Then we should examine for the skin examination to rule out the neurocutaneous and look for a spine if there is any occult spinal dystrophism by change in the color, pigmentation, or tuft of hair, as this may be associated with structure abnormality like in Chiari malformation. Then we should examine for the visual field, fundoscopy, otoscopy, and oropharynx, then neurological examination for the lung tract sign and for the cerebellum and sensory examination. Step 2, we should identify the red flag either by history or exam, as we said before. Here, an example of headache characteristic that with red flag for the patient: headache that awake a child or occur constantly upon awakening from sleep, short or paroxysmal headache, thunderclap headache, uncommon in children, associated neurological sign or symptom like persistent nausea, vomiting, or altered mental status, headache worsen in recumbent position or by Valsalva maneuver like in Kaplan micturition, absence of aura or aura that lasting for more than 1 hour, chronic progressive headache pattern, change in quality, severity, frequency, or pattern of the headache, occipital headache, recurrent headache, localized headache, lack of response to medical therapy, headache duration of less than 6 months. This is all a red flag. Patient history as well, inadequate history, description of the headache and relative feature, risk factor for intracranial pathology, as we said in the past medical, if the patient has underlying cause like sickle cell immunodeficiency, coagulopathy, or neurocutaneous disorder. If age less than 6 years, personality change, deterioration in schoolwork, associated symptom of the neck or back, family history. If there is absence of family history of migraine, this is a red flag. In the examination, if the patient uncooperative, unable to complete neuro exam, this is a red flag. Abnormal neuro exam like ataxia, weakness, diplopia, abnormal eye movement. If a patient has a papilledema, if a patient has growth abnormality, increase head circumference rapidly, specifically in neonate or infancy, short stature or deceleration of linear growth, this may indicate endocrine problem. or pituitary tumor, nuchal rigidity. This may indicate infection or subarachnoid hemorrhage, sign of trauma, cranial bruit, skin lesion. That is just neurocutaneous disorder. This a nice mnemonic for a red flag as a SNOP4 is systemic in the history of malignancy, immunosuppression, and etc. Physical exam, if a patient have abnormal systemic examination, include blood pressure or high temperature. N for neurologic, if a patient has a focal or proper neuro symptom, including a change in behavior or personality, diplopia, transient visual obscuration, or pulsating tinnitus. In exam, if a patient has abnormal neuro exam. And onset, if a sudden, as a headache reach peak intensity in less than 1 minute, this is what we call thunderclap. And onset, as we said, if age less than 6 years. Better for P pattern change if a progressive headache, affiliation to daily headache, or a change in the headache character, or precipitated by Valsalva maneuver or postural aggravation. If there is a papilledema on examination, and in adulthood, if there is a pregnancy, and the last P is phenotype of rare headache, like a trigeminal, which is rare in children less than 10 years. Investigation depend on what we found in the history exam and what we have a red flag. Depend if the patient has a trauma, a neuroimaging needs CT, but better for most of the secondary headache that indicate underlying brain or brain tissue problem or other malformation, is MRI is the best choice. However, depend how the patient is present and how is acute. If need immediate intervention, CT will better for acute or rapid intervention. MRI for better visualization of the brain parenchyma. Laboratory, usually in primary headache not needed, usually in the secondary headache, as in a patient to do blood to know if there is a leukocytosis infection, and if we need to rule out meningitis, encephalitis, or subarachnoid hemorrhage, can we do CSF? And the patient, if we think about a headache secondary to substance use, we can do a toxin from the urine. EEG usually not helpful unless we're thinking about the seizure and the patient has a real convulsion, or the criteria can fit one of the epilepsy syndrome. Stage 4, we important to categorize primary headache. We'll talk mainly about the most common is, and this depends on the based on ICHD3. We'll talk about the most common is the migraine and the tension type. We have a migraine. We have migraine without aura, at least 5 attacks lasting from 1 to 72 hours, at least one of the following: nausea and or vomiting, and the patient has a photophobia and phonophobia, and at least 2 of the following 4 objects if the patient have unilateral or pulsating or moderate to severe or aggravated by the daily activity, not better accounted by another diagnosis. If a patient has, we think about migraine with aura, the same the criteria before, but can we add 1 or more transit focal neurological sign, aura, like if a patient have a visual, sensory, or physic or motor, and gradual development of the aura symptom. Aura should be lasted from 5 to 60 minutes, followed by or accompanied by a headache within 60 minutes, but should not be lasted more than 1 hour. Tension type headache, at least we have 10 episodes of headache, duration from a half an hour to 7 days, at least 2 of the following: if it's bilateral tight or bracing, not pulsating in a migraine, mild to moderate in intensity, not activated by unactivated or aggravated by routine activity, both of the following: no nausea or vomiting, no more than 1 of photophobia or phonophobia. Trigeminal autonomic cephalgia include many of disorders like cluster headache that lasts from 15 to 180 minutes, paroxysmal hemicrania that lasts from 2 to 30 minutes, hemicrania continua, or short-lasting neuralgia, unilateral neuralgia form headache attack that last from 1 to 600 seconds. We have both type, conjunctival injection and tearing that we call SUNCT, and a patient with autonomic symptom like SUNA. Other primary headache, which that just we know, we'll not talk about it. Headache associated with the physical exertion, like a primary cough headache and primary exercise headache, a headache attributed to direct physical stimuli called the stimulus headache, or external pressure headache, epicranial headache like a numeral headache, and etc. Step 5, depend plan and management. What we found, the patient has had a secondary or a primary cause. However, a primary cause can present with acute and like in status migraines. We have approach general measure. If a patient has a secondary cause, we should follow SMART mnemonic for stabilize the patient, monitor the patient, act with the patient, proper referral to the patient, and time in the timeline. If the patient has a secondary headache, a primary headache, sorry, SMART indicate sleep properly, take meal, activity, and trigger avoidance and R for relaxation. Abortive treatment, this must or should be start early with enough dose, depend on what we have, what we found in the patient, either primary or secondary. Prophylactic treatment, these usually for the chronic headache like migraine that we have. Also, we should know about the comorbidity to proper choice of the treatment. The treatment not usually only by the medication. We have other treatment like a behavioral therapy and etc. This is the key point, and now we come to last slide. Key red flag in our mind: rate of child headache to be serious cause. Be familiar with ICHD3, especially in the primary headache, to categorize the patient which primary headache and to proper intervention. Education is the important, and headache diary as well. And thank you so much.
Thank you, Dr. Sehemi, for this great talk. Now we will conclude our second session today, and I would like to invite all the speakers. I have few questions. The first one for Dr. Ayat regarding febrile convulsion. I have two parts. The first part, in case of provoked seizure with fever, if there is no meningeal signs and no focus, shall we investigate or not? The second part is when to refer the patient to pediatric neurology. As a general pediatrician, what is the indication to refer the patient to pediatric neurology? Dr. Ayat? Dr. Ayat? Okay, is Dr. Ba'arma is around? Dr. Ba'arma?
Can you repeat the question, Doctora?
For Dr. Ayat, is she around?
لا هو بس يعني the second part was إنه when do you refer to pediatric neurology? The first part لأني ما انتبهت بس.
The first part for provoked seizure with fever. If there is no meningeal signs and no focus, no
okay.
clear focus.
خلاص okay. Yeah. Okay.
So shall we investigate?
دكتورة آية لما قدمت الفبرايل seizures. Okay.
أيوة. طيب دكتور بليغ, can you take this question?
طيب she mentioned دكتورة آيات إنه it depends on the patient's age. If he is younger than 18 months, it's difficult to elicit meningeal signs, and the presence of otitis media or pharyngitis does not exclude the presence of CNS infection. But if it's difficult, if in that age group, you have to be very careful, and not discharge the patient on just being febrile seizure. Like if he's an older patient with no meningeal signs and he's okay, and you have a clear focus and the patient is back to baseline.
No, this patient has no clear focus.
Yeah.
No focus, no obvious focus. And he only presented with provoked seizure with fever, but no clear focus.
Sure.
And no meningeal signs. So should I go for investigation or not?
It depends on the age. If he's in a younger age and below 1 year, definitely. 1 year to 18 months, still we have to be careful. If he's above that age period, if he's 2 years مثلا سنة ونص سنتين, then meningeal signs can be elicited. However, it may be variable with the technical skills of the clinician seeing the patient. This would be my short answer. The long answer would be, if there is no family history, and تقريبا 25, the majority of cases will not have a family history, and those that have family history will have an autosomal dominant variant. So, but you have the majority of cases, they don't give you family history. So the absence of family history does not exclude the febrile seizures. However, the age factor and how sick the patient is would play the #1 role. A normal CBC or the absence of these other findings do not rule out meningitis. You have to always be careful with these type of things. And usually viral encephalitis carries a milder course than bacterial meningitis, in which some patients might return to almost baseline with the drop of fever. So it's always a clinical judgment that plays major role.
Okay, thank you, Dr. Baligh. Dr. Baligh, for your session, can transverse myelitis present with the on and off sensory symptoms without sensory level?
I mean, in the beginning, in the first few hours, maybe. Like again, transverse myelitis is usually very abrupt, very sudden, and the picture will be clear within an hour or so. Again, sometimes what might happen is that the evolution of the disease will take 1 or 2 days maximum, as opposed to Guillain-Barré, which may take days for it to evolve. Like usually in transverse myelitis, there is always a sensory level. If you don't find the sensory level, then you find the other sensory abnormalities that we've mentioned: the tingling sensation, the pain, the radiating pain, the backache, all these things, you will find it. Having said that, patients with Guillain-Barré may also have these type of sensory abnormalities in pediatric population per se.
Okay. The second question is: the absence of enhancement of coda-equine or nerve roots can rule out GBS on MRI?
Can it rule it out? It makes it less likely. It makes it less likely, but it doesn't rule it out.
Okay, thank you. Is Dr. Sulaiman or Dr. Dua around?
One just to add on the point of MRI and MRI changes, we always have to remember that doing lumbar puncture may cause leptomeningeal enhancement if you do the MRI after that. So always try to do the MRI before the lumbar puncture.
Okay, good. Okay, I think we can conclude our session today. Thank you for all the attendance and speakers. Hopefully you enjoy it, and thank for the organizing company and Saudi Pediatric Neurology Society for this great event. Thank you all. See you again.
Thank you.
Thank you, everyone. Thank you so much.
Thank you. We reach the end of our day today. Thank you.